type of the tumor, I've come across anywhere from 10% to 40% of patients have brain metastases. And sometimes, and oftentimes, they are clinically occult. So part of that is pathologic data. But having said that, that is why it is important to evaluate patients for brain metastases, because we know the poor prognosis that's associated with patients that have this type of extension. So when we look at brain metastases, I think we're all pretty familiar about the imaging findings. They're typically enhancing masses. Oftentimes they're round, but they don't necessarily need to be. They tend to arise at the gray-white junction and the watershed regions. And part of this is because of the smaller arterioles. And also, the farther they are from the feeding vessels, the less push, if you will, there is. So that's why they tend to deposit at the gray-white junction, the watershed region. We know that they can be single or multiple. They're oftentimes associated with this edema. And also, brain metastases can be associated with different forms. You can have bone lesions, but also in this patient with adult medulloblastoma, this nicely demonstrates the leptomeningeal metastases that we can see in brain metastases. So this is just an example here of a deposit at the gray-white junction associated with the vasogenic edema. So these are all the typical spectrum, if you will, between this slide and this slide of the various imaging findings of brain metastases. Now, I hate to say this, I was born in the last century, and I trained in the last century, and I was actually trained in the Harvard system, and I was at the Brigham and Women's Hospital. First time we ever gave gadolinium on a brain MRI. And the reason why I mention that is, but ever since those days, over 40 years ago, we've still been struggling about ways that we can separate primary tumors from solitary metastases. And that is still going on even in 2024. So what I'll do is I'll go over the different types of metastases and talk about some ways that you can help identify metastases and separate these from metastases mimics. So on the top here, this is just a classical example of metastases I mentioned before at the gray-white junction. And this is an example of glioblastoma multiforme. So when we see the GBMs, metastases can be solid, they can be rim enhancing, but when we see something like this, which is a larger mass that has this very, very shaggy margin and has this solid component that's extending within the lesion, and also with the substantial of vasogenic edema, certainly we think the possibility of glioblastoma. So I think this is a fairly dramatic case of a GBM. And in general, I don't think any of us would confuse a GBM from the solitary metastases that I show. But on the other hand, this is a patient that has lymphoma. So when we look at this patient that has lymphoma, if we look at the T2 weighted images, we can see a mass here involving the centrum semiovalli and periventricular white matter of the left frontal lobe, and this periventricular abnormality. And the contrast enhanced study shows multifocal lesions. So what are some ways that we can separate lymphoma from metastases? First of all, on the non-contrast CT, what we see is this area of more increased attenuation than we typically see in a metastases. And this is felt to be related to the hypercellularity of the lymphoma. Lymphoma also tends to involve the deep gray matter, specifically in the basal ganglia. And it also has a predilection to occur in the periventricular white matter. So from my standpoint, if I look at a CT scan and I see increased attenuation, and then I see enhancing masses located in the deep gray nuclei, or I should say the basal ganglia and these various lentiform nuclei, and then also look at the periventricular white matter, then I start thinking about lymphoma. Now, this is an example of melanoma metastases. So when we look at melanoma metastases, as we know, they're hypervascular and they have a predilection to hemorrhage. So if I am looking at a lesion involving the brain and I'm trying to figure out whether it's a metastases or not, or specifically the type of metastases, if I look at the non-contrast CT and I see these areas of hemorrhage, then this suggests that this is a hypervascular lesion. We know various lesions can be hypervascular. I tend to use the mnemonic MATCH, which is melanoma, anaplastic lung, thyroid, choriocarcinoma, and hypernephroma. So those are my mnemonics for these hypervascular metastases. And when I see this frank hemorrhage, then that really leads me to the diagnosis of melanoma. On the non-contrast T1 weighted images, we can see the T1 shortening. This is likely either due to melanin or some type of methemoglobin. Methemoglobin typically has increased T1 signal. Here we can see the surrounding vasogenic edema. And in this case, in melanoma metastases, on the T1 weighted images, we see hemosiderin. Now, if we see hemosiderin, in this case of melanoma metastases, now we have to think, is this due to blood products from melanoma, or could it be due to another etiology, another pathology? And when we do think of blood products and hemosiderin, and if you will, what we refer to as blooming artifact, we always have to consider cavernoma. So this is an example of a cavernoma. So here we can see increased attenuation on CT, high T1 signal on the non-contrast T1 weighted image. These lesions tend not to enhance. And again, we can see this blooming on the gradient echo sequences. Why I would suggest that this is a cavernoma and this is a melanoma metastases is because of the surrounding vasogenic edema. Now, sometimes cavernomas can bleed and you can have the vasogenic edema, but in general, cavernomas are oftentimes incidental, whereas melanoma mets tend to have this vasogenic edema. Now, this is an example of multiple ring-enhancing lesions in the brain that have surrounding vasogenic edema. Here we see the nice ring-enhancing lesions, and this is a nice example of abscesses. So when we see something like this, we have to often ask our patients, are the patients febrile? And we know that abscesses in about 50% of the patients are afebrile. So sometimes that clinical history is not beneficial. So when we see these ring-enhancing lesions, they sort of have the typical appearance of an abscess, but as neurosurgeons and radiologists, I always say we don't get older, we get more experienced. And those of us that are more experienced, if you will, have seen metastases look exactly the same. So the challenge is how can you separate abscesses in afebrile patients from metastases? Well, one way that you can do this is to look at the ADC maps. And ADC maps are not 100% when we look at restricted diffusion. But in general, if we look at the abscesses, the amount of edema surrounding the mass tends to be greater than what I've seen in abscesses. It's hard to quantify this, but it's just something that has been reported and something that I've seen. So if it's something that I'm not sure about and I'm trying to differentiate, in my own mind's eye, I try to determine the surrounding vasogenic edema with this ring-enhancing mass. Abscesses have also been described to have decreased peripheral T2 signal and flare signal, so you can see this dark rim here. And then when we look at the ADC map, this is what we described as decreased ADC within the abscess. Now, when this was first described, it was felt to be pathognomonic. As with everything in life, nothing is 100%. And I've certainly seen metastases have decreased ADC. But on the other hand, if I am looking at something and I see a lot of surrounding vasogenic edema, I see this peripheral area of decreased T2 and flare signal, and then I look at the ADC map and I see diminished signal here, then I certainly consider the possibility that this, in fact, could be an abscess, and that needs to be further evaluated. Here's another example, not necessarily abscesses, but these are multiple septic emboli. Again, I've seen brain metastases look exactly the same. Again, in the afebrile patient, it's going to be oftentimes very difficult to differentiate. So we do have to rely on whether the patient has a known history of any type of tumor, whether the patient is febrile. And I think in something like this, I know we see this a lot in our practice. We have our tumor boards every Tuesday morning. If we see something like this, one thing that you can do besides trying to biopsy this is go ahead and work up the patient for any cardiac abnormalities. It doesn't take a lot to do a echocardiogram to see if they do have a ventricular septal defect. You also want to know if the patient has undergone any type of recent dental procedures, because patients that have dental procedures can often get showered with these various septic emboli. So nothing really specific when it comes to the imaging findings, but we always want to see if there's any relevant history that can push us to help separate septic emboli from multiple metastases. This is something that can be confusing. This is an example of acute multiple sclerosis. Again, if you look at this, it can look exactly like metastases. How can we make the differential diagnosis and the separation? Number one, when you do have this ring enhancement in multiple sclerosis, it has been described that the margin of the enhancement adjacent to the ventricle tends to be less enhancement than compared to the outer margin. So we can see the thick margin here, but a thinner margin along the medial side adjacent to the ventricle. So I know that's helped me in the past. When we look at the contrast enhanced study, again, very, very hard to differentiate. But in this particular case, we can see abnormal enhancement involving the left optic nerve. So if we do have someone that presents with some unusual symptoms and they tend to have something like optic neuritis, as is seen here, this can push us over and say that this is not a metastases, but rather this is a form of multiple sclerosis in a patient that presents with unilateral vision loss. And this is an example of something that can be confusing. This was Balo's concentric sclerosis. Sometimes the imaging findings can be difficult, the clinical history can be difficult. But again, here we see these incomplete margins of enhancement, and notice the location. They are along the periventricular white matter. So in metastases, we would expect to see a full rim of enhancement. Rather, we see the segmental peripheral enhancement. And again, this can tip us over that we're dealing with a demyelinating process as opposed to a tumor. Subacute infarcts can also mimic this. This is a small area of enhancement here involving the left frontal operculum. In this particular case, when we look at the ADC map, we can suggest a diagnosis of an infarct based on the increased DWI signal. And again, sometimes that history can be confusing. But again, this is where looking at all of the sequences on MR can be very helpful. Just to complete the differential diagnosis, because we do have a global audience, if you are coming from an endemic area, this is an example of cysticercosis, again, involving the gray-white junction. We can suggest cysticercosis here and also potentially tuberculosis because we can see the decreased T2 and flare signal. This is an example of a patient that has hydatid cysts. I know we have people from the Middle East. And I think if we see this, we probably won't confuse this with metastases, rather classic hydatid cyst. In the United States, we see a fair amount of sarcoidosis. In sarcoidosis, you oftentimes see this plaque-like enhancement, which is involved in the dura, and sometimes you can have this peel involvement. Now, this could easily be due to lymphoma or other type of leptomeningeal disease, but in this case, it was sarcoidosis. And this is an example of radiation necrosis. This patient had enucleation and underwent high-dose radiation. If you look at this, you're not really sure what it is. You have to include the possibility of metastases, but it's always important, if you do work closely with your radiation oncologist, to know exactly where that high-dose radiation field was. So we saw this and we knew it was a high-dose field and we felt it was probably radiation necrosis. And then about a year later, unfortunately, this thing blew up and this was all radiation necrosis. So if you see something like this in a patient that has undergone some type of craniofacial resection and has undergone radiation therapy, please look at the high-dose field when you partner with your radiation oncologist. We can use a variety of metabolic imaging studies. This is an example of spectroscopy. So in spectroscopy, something that I'm quite familiar with, just to give you a brief example, there's the choline, which is a marker of cell membrane turnover, which is located at 3.2. There's creatine, which is a store of high energy, which is 3.0. And then in the brain, we have NAA, which is this neuronal tissue. Normally, choline should be low, NAA should be high. So when we draw our arrow here, it should be upward pointing. But on the other hand, when you do have metastases or any type of aggressive tumor, because these tumors have rapid cellular turnover, this higher cellular membrane turnover in choline should be higher. And because it's replacing your normal neuronal tissue, your NAA should be lower. So when actually this arrow should be pointing downwards, and this is more indicative of recurrent tumor. So if you're trying to differentiate recurrent tumor from post-treatment changes, if you have this downward pointing spectroscopy, this is more suggestive of metastases as opposed to bland radiation changes. I'm sure all of you are familiar with perfusion imaging. This is an example of perfusion imaging. I don't have time to get into the details, but suffice it to say that the best marker for perfusion is going to be cerebral blood volume. So when we look at our blood volume here, we can see it's brighter. This indicates that this lesion has higher blood volume, and therefore it's more likely to be due to metastases. This, on the other hand, are radiation changes. We can see this mass here involving the periatrial region. And then when we look at the perfusion, we can see there's decreased perfusion. So this is more suggestive of radiation changes. So the last thing that I wanted to do is very quickly is to talk about some of the practical issues, because I think all of you are familiar with a lot of things I talked about. But I did want to mention a couple of things that are probably very variable, things that keep me up at night. So what I mean by this is I know that about 10 to 40% of patients will have brain metastases. But it's very important that if you are either resecting patients with brain metastases or you're treating these with some type of non-surgical therapy, I want to emphasize the fact on how important technique is when you're evaluating not only preoperatively, but you're monitoring this. Realize that MR is better than CT for detecting metastases. Also, the ability to detect metastases depends on various factors that are oftentimes glossed over and they're not recognized. So realize when you are following up these patients, it's important that you image the patients on the same field strength magnet. Realize that a 3T magnet is going to give you better detection than a 1 Tesla magnet. So the patient's done on a 1 Tesla magnet, then they're done on a 3T magnet, and you see more metastases. That doesn't necessarily mean the patient's gotten worse. It's possible it wasn't detected on the 1 Tesla magnet. So it's important to have a consistent field strength. It's also important that your T1 weighted sequences are consistent. Realize that 3D gradient echo sequences are oftentimes sub-millimeter, whereas standard T1 weighted images are oftentimes 3 or 4 millimeters. So you're going to get better detection of the metastases when you do these stealth-like sequences. So again, important to note that. And also the different contrast agents. We all talk about gadolinium. I'm sure all of the neurosurgeons on this audience and everyone else is familiar with gadolinium. But realize different types of gadolinium have different inherent components, and some are going to be more sensitive than other components. So again, when you are monitoring the response, please work with your radiologist to make sure that the type of gadolinium that you're giving is also consistent as well. So because of this, I want to make sure that you really emphasize your technique. So my take-home messages is that imaging is important for the detection of brain metastases. We have to be familiar with the characteristics of different types of brain metastases and not confuse these with various mimics. Please, please, please make sure that your imaging technique is optimized and consistent for post-treatment images. Again, something that we don't emphasize enough. And that there is an evolving role for various biological and physiological techniques, such as spectroscopy and perfusion, and sometimes ADC as well for treatment monitoring. So thank you very much for the privilege and the honor of being here. And if it's okay, I'm happy to take any questions now before I have to sign off for my next presentation.
Thank you. Thank you, Dr. Mukherjee, for giving one of the best lectures I've heard on metastasis. Um, there are a few questions here on this Dr. Harsh Pares from India. He has asked, how do you differentiate a multicentric GBM from metastasis?
Right. So that's a great question. So again, the multicentric GBM, this is what I would suggest, is that the multicentric GBMs tend to, at least in my experience, some tend to be necrotic, some tend to be solid. And part of it is the ability to look at the geographic distributions of the T2 and flare signal abnormality. So what I mean by multicentric GBMs is that oftentimes not all of those components have areas of enhancement, whereas the metastases will have increased flare in T2 signal surrounding the enhancing component. So in general, metastases will have the enhancing component with the surrounding vasogenic edema, whereas the multicentric gliomas, there will be a component that enhances, but sometimes there's flare in T2 signal that doesn't enhance. So when I see this inconsistent or heterogeneous pattern, that leads me more towards multicentric glioma versus metastases.
Thank you, Dr. Mukherjee. Do any of the other speakers have any question? Dr. Dwaraka? If they don't have, I have a question. Can you please repeat? What I understood is when you do a serial scans, it's important to do with the same Tesla to evaluate the progression or reduction of resolution of disease. But you stress something on the gadolinium. Can you please repeat it?
Yeah, can I just share that slide? Thanks for mentioning that because it is something that is just that I don't believe is underemphasized. So the premise of this is that anywhere from 10 to 40% of patients will have metastases. There are different ways that we detect metastases. There are different factors that are integrating that are integrated into the most accurate detection of metastases. Part of this is sequences. So the lower your field strength is, so many of you may have less than 1 Tesla, 1 Tesla, 1.5 Tesla. The lower the field strength is, the less likely you are to detect lesions. The second thing is that the thinner your sections are, the more likelihood you are going to detect lesions. So make sure that your follow-ups are using on the same field strength and then also the same slice thickness. The other thing is that when we look at gadolinium, not all gadolinium agents are the same. There is something that's referred to as T1 relaxivity, which basically determines the brightness of gadolinium that we see once we take these images with MR. So these gadolinium agents can be linear or they can be macrocyclic. And in general, some of the linear agents have a little bit better relaxivity. They're a little bit brighter. But the macrocyclic agents tend to be safer. They tend to be associated with less side effects. And we went through something called NSF, nephrogenic systemic fibrosis. These compounds, the macrocyclic compounds, tend to be much safer when it comes to this. But my point is that when you are doing your follow-ups, just try to make sure, and they're probably doing this already, but try to make sure the same contrast is used. Practical aspect occurs is that if you have patients that are getting their follow-up imaging studies at different sites, it's possible they could be using different field strengths, they could be using different types of sequences, and they could be using different types of gadolinium. So when you are doing your monitoring, that's when this large variability comes up that may not give you an true accuracy to determine whether or not your treatment has been effective or not.
So it boils down that for follow-up, it's better to do at the same center so that consistency is there in the technique and the type of gadolinium they use.
That would be my opinion.
Yeah. The two more questions. Yes.
So Mukherjee, that was a nice talk. So when we're doing radiosurgery, I mean, the different MRI sequences have different the error margins. For example, 3 Tesla and 7 Tesla, even though they show more lesions, they tend to have a more distortion than compared to 1.5 Tesla. So how does your center go about neutralizing this when you're using these high density images for high Tesla images for planning?
Right. Yeah, thanks for the question. I actually have a joint appointment in radiation oncology too, so it's nice that to see another radiation oncologist on the phone, on the member. So I can try to answer this briefly, is that in general, 7 Tesla has not really made it in prime time yet. Unfortunately, again, I trained in the last century, and I remember when 3 Tesla happened. It took us about 10 years to really become familiar with 3 Tesla. A lot of it is to better coil technology, et cetera. So as far as 7 Tesla is concerned, I probably wouldn't advocate 7 Tesla right now, especially from the distortion artifacts at the skull base. In general, 3 Tesla, if you are using the proper coils and you are using the proper sequences, in general, we don't see nearly as much distortion with 3 Tesla. Because this is a global audience, if you had to default to something, I would probably default to the magnet that's more consistent and then use some type of stealth or 3D sequences to do your acquisition. But I think in general, with 3 Tesla now, it is mainstream. And in general, I don't nearly see as much distortion artifacts in the brain from 3 Tesla. Now, the spine is different. I'm still a little bit leery about looking at spinal metastases on 3 Tesla, but I think the brain metastases, I'm pretty comfortable with the quality and the consistency of the imaging.
Yeah, you have 2 more questions, then we go to the next talk. How do you differentiate sarcoidosis from acute MS? And the other question is, how do you differentiate the edema between GBM and a metastasis?
Sure. A sarcoid versus multiple sclerosis, in general, sarcoid tends to be more linear and a little bit more solid. And for a patient to initially present with intracranial sarcoid extension without having systemic disease is pretty rare. So, and also sarcoid tends to not have the ring enhancement, and it also tends not to occur periventricular. Sarcoid tends to be more leptomeningeal, periventricular, and sometimes it can extend along the perivascular spaces involved in the deep brainstem, as opposed to the perivenular spaces that we kind of lovingly refer to as Dawson's fingers. So that's how I differentiate between those two. And then, I'm sorry, what was the second question? I apologize.
Second, the edema, how do you differentiate the edema in GBM and metastasis? Is there a difference?
So that's a great question. Let me mention one thing, and this is somewhat controversial, but sometimes what happens is it's physically impossible for us to differentiate small GBMs, solitary GBMs from metastases. It's very, very hard because the perfusion doesn't help and the spectroscopy doesn't help when we place it on the solid component. So my feeling about GBMs, and again, it's just my opinion versus metastases, is that GBM is truly a systemic disease. And I know there have been numerous studies that have been done that have identified that the edema surrounding GBMs also contain elevated levels of choline. So one way to go about this is that you could potentially perform MR spectroscopy and place it on the edema surrounding the GBM. And if you see elevated choline in that surrounding pure vasogenic edema, that's more suggestive of GBM. Whereas if you place that edema surrounding the metastases tend to be more confined and there's no choline. Similarly, there have been studies that have been done with perfusion suggesting that the edema surrounding GBMs have elevated perfusion. Again, I don't know if that's enough to really change your treatment, but I just wanted to let you know that these are some ways to potentially use biologic/physiological imaging to help us separate GBMs from metastases in those images that have overlapping features.
Yeah, thank you, Dr. Suresh. I do have some questions. I'll send an email to you because you're short of time. We'll go to the next paper. After having diagnosed how the metastasis can be diagnosed, we go how it has to be treated when surgery has to be done by Professor Mitsuya from Japan. Professor Mitsuya, can you please share your slides, please?
You must click the green share button. Dr. Misuya. He disappeared.
Should he go off to the third talk and come back to second? He has come back again, yeah. He's there.
Please.
Yeah, we can hear you. We need to see the scan.
Yes.
You can share your screen.
Yes.
Yeah, we can see the screen.
I'm sorry.
Yeah.
No problem.
Thank you, Dr. Panigrahi and Dr. Girelli. I'm honored to have the opportunity to give my talk. I'm Dr. Mitsuya, Division of Neurosurgery, Shizuoka Cancer Center in Japan. Today, I'd like to talk about management of brain metastasis, especially regarding surgical indications. These are today's contents. Surgical resection plays an important role in the management of patients with brain metastasis. Standard indications for craniotomy include 1. Diagnostic uncertainty. 2. Brain metastasis causing symptoms refractory to steroid. 3. Bulky metastasis, typically 3 or 4 centimeter oversize. 4. Solitary brain metastasis. Importance of pathological and molecular diagnosis. This case, suspect of lung cancer, but bronchoscopy is difficult, challenge 2 times failure. So, suspect of brain mets, surgical resection, pathological diagnosis, non-small cell lung cancer, TTF1 positive. PD-L1 tumor population score is 60%. Molecular diagnosis, driver mutation negative. So, systemic therapy, immunocheckpoint inhibitor be effective. Now, this is a preoperative prognostic marker. We report preoperative neutrophil to lymphocyte ratio, NLR, related to cancer and inflammation and cancer immunology. On terminal stage, NLR increase. Median overall survival after resection brain metastasis, NLR under 5 is 14 months, but NLR over 5, only 5 months. Predictor of worse survival after resection. Surgical resections advantages resolution of mass effect and edema immediately. Rapid steroid tapering. Rapid neurological recovery. Simplified radiographic interpretation. Recurrence versus radiation necrosis. Histological confirmation of the ridge. Disadvantage may cause delay of primary cancer treatment. Requires general anesthesia. Invasive procedure. In the era of development pharmacotherapy, prognosis of the patient with surgical resection of brain mets is improved. This paper, non-small cell lung cancer BMETs. After resection BMETs, median overall survival, surgery plus radiation therapy and chemotherapy is 11.8 months. But surgery plus radiotherapy and immunocheckpoint inhibitor is 23 months. So a long survivor, next theme is improve local control and avoidance of leptomeningeal disease and reduce of adverse events, cognitive function and radiation necrosis important. Next, 2 methods of surgery for brain metastasis. Near eloquent area, recommended minimum resection Near pyramidal tract, minimum resection is recommended. Dissection of gliotic tissues, don't dissection on the tumor, and insert cotton putty around tumor margin. Infiltrated tumor cells in brain, risk of local recurrence. This paper is very important from BOMAT. Non-small cell lung cancer and sarcoma, breast cancer, brain metastasis. Mean depth of infiltration is 1 millimeter, but small cell lung cancer and melanoma mean depth of infiltration is 2 millimeter over. Risk of local recurrence. This paper is Mahajan from Mahajan, MD Anders Cancer Center. Problem after surgery, local recurrence. Surgery alone versus surgery plus SRS phase 3 randomized control trial. Surgery plus observation, local recurrence 6 months, 34%. Local recurrence 12 months, 57 months. Very high rate. Surgery plus cavity SRS, local recurrence 6 months, 15%, 12 months, 28%. Non-eloquent area, we recommend removal of safety margin. Non-eloquent area, uncapping technique and removal with safety margin, improve the local control, protect leptomeningeal dissemination. This is salvage surgery for local progression of brain metastasis previously treated with STI. Recurrence after STI, tumor margin is irregular. So we recommend fence post method, removal with safety margin. Median overall survival, 20.2 months. Two removal techniques of brain mets. Piecemeal resection, deep and large tumor, eloquent area, less invasive for surrounding brain, but high dissemination risk. This is dilemma. Unblocked resection, superficial and smaller tumor, non-eloquent area. Piecemeal resection is leptomeningeal dissemination high-risk case. This paper report unblocked resection is 3% incidence of LMD, but piecemeal resection is 9% incidence of LMD. Advantage of neoadjuvant SRT, I think. Problem after surgery, risk of patchy meningeal failure. This paper also piecemeal resection is high risk. We report intraoperative cotton dam wash cytology, diagnosis of intraoperative LMD, and prevention of postoperative LMD. Next, neoadjuvant STI background, large brain metastasis randomized control trial, a Patchel report, surgery plus postoperative WBRT, long survivor cognitive function down, surgery plus post-op SRS, Mahajan and Brown, surgery plus salvage SRS from Kayama in Japan. New strategy, neoadjuvant SRS followed by surgery. Postoperative left meningeal dissemination improve. Symptomatic radiation necrosis improve. Our institute, 20 patients, small case series, pilot study, 5 fraction SRT, neoadjuvant fractionated stereotactic radiotherapy, followed by piecemeal resection of brain metastasis. Local recurrence is 5%. Left meningeal metastasis, 5%. Symptomatic radiation necrosis, 0%. Representative case, lung cancer, premotor region, 4.6 centimeter. Large and deep metastasis. Hemiparesis, very severe. KPS 60. Preoperative SRT followed by piecemeal resection. After surgery, KPS improved. Hemiparesis improved and systemic therapy. Small cortical incision and run nearby very cortical vein. Small cortical incision and piecemeal technique needed. Prospective study in Japan, PI is Mitsuya. Now is ongoing. 57 patients in Japan. Brain metastasis 1 to 4. Maximum diameter 2 to 5 centimeters. Neoadjuvant SRT 5 fraction within 14 days surgery. MRI follow-up every 3 months. Primary endpoint, local control. Secondary endpoint, symptomatic radiation necrosis and left meningeal dissemination, and so on. Preoperative SRT advantage and disadvantage. Potential advantage, local control, improve. Left meningeal disease and radiation necrosis avoid. Disadvantages, lack of pathological confirmation before SRS. Not compatible with emergent surgery. Next, palliative CSF shunting for left meningeal metastasis related to hydrocephalus in patients with lung adenocarcinoma. We report 31 patients. Post-op performance status improved, TKI per os. PS 1 to 2, median overall survival of 7.7 months. CNS BBB intraperitoneum, no barrier. So after surgery, systemic chemotherapy, TKI or ADC, carcinomatous peritonitis avoided. Fox regression analysis, ECOG PS at diagnosis of LM, and controlled extracranial disease, post-shunt TKI. Important of early diagnosis. Early diagnosis of left meningeal metastasis is important. This is non-contrast enhanced type left meningeal metastasis. Clear hyperintensity along the brainstem surface in left meningeal metastasis. Our hospital, all cancers from LMD, Bloomy line sign, 11 patients, 7.7%. All lung cancer adenocarcinoma, EGFR positive cases. We report bloomy line sign, bloomy line cheese like diagnosis, sugar coating type is too late. So this phenomenon is early diagnosis of left meningeal important. This is last slide. Management of brain metastasis surgical indication. Overall survival is improved. The patient with brain mets after surgical resection in the era of STI and developed pharmacotherapy. Tasks improve local control, avoidance of LMD, reduce of adverse events. Multidisciplinary approach is important. Thank you very much.
Yeah, thank you, Professor, for giving a lucid lecture on when to operate and what is the role of pre-radiation and surgery in metastasis. We'll have the questions and answer after all the three lectures. And I request you to please wait till the end of the session. The next lecture is after surgery is when to give radiosurgery, and by Professor Dwarakanath Srinivas from NIMHANS, National Institute of Mental Health and Neuroscience, Bangalore, India.
So can you see my slides? And
Yes.
Thank you. Thank you, sir. Thank you for the invitation. So we are at a changing paradigm of management in which radiosurgery is gradually taking over the functions what whole brain radiotherapy used to do 20, 30 years back. And this is primarily, and the epidemiology of brain mets, which has already been mentioned, is that we are going to see more and more brain metastasis for treatment for the simple reason that because of the advances in treatment for the primary malignancy, patients are living longer and there is an increased life expectancy and improved survival. So like the radiology was already mentioned, so I'll not go through it. Again, you have basically two types. One is the well delineated ones, and one is the leptomeningeal origin types, which causes a diffuse coating and which are basically not suited for radiosurgery. So the question is, how do you manage brain metastasis? Would you like to treat the patient aggressively? Would you treat based on the number of metastases? Would you be treating on the basis of the pathology? Would you treat the systemic profile? Would you include the immunotherapy into the treatment paradigms? So there are many factors which you need to take into consideration before you start your treatment. And the question is, and this was a scale which was developed in the 1960s, which gave basically a graded prognostic assessment based on these four main features of age, KPS, number of CNS metastases, and extracranial metastases. And then the score was given, and the higher the score, better the survival. The question is whether the different primaries have a different survival rate. If you see over here, regardless of the primary, the average survival is more or less the same, slightly higher, slightly lower. Again, in breast cancer metastasis, the genetic also plays an important role in the prognostication. So what treatment modalities do we have? One, of course, we have the steroids, which are basically palliative along with anti-seizure medications. Some centers use external beam radiotherapy as palliative, and the median survival is less than 15 weeks. The aggressive treatment is basically surgery or radiosurgery, along with whole brain radiotherapy and chemotherapy and immunotherapy. So let us first discuss what are the controversies in management. One is, of course, the solitary brain metastasis, where the controversy is whether to use surgery or SRS and whether to give WBRT or not. Then group of 1 to 4 metastases, and the third group is greater than 4 to 5 metastases, where the primary discussion is between SRS versus whole brain radiotherapy. Like the previous speaker mentioned, the landmark study by Patchell, of course, proved that surgery, complete excision followed by whole brain radiotherapy definitely improves the survival significantly. And the current recommendations for surgery include predominantly solitary lesions more than 3 centimeters, providing diagnosis if none exist, gives you tissue for molecular subtyping, relieves symptoms due to mass effect, gives you complete local resection, avoids steroid deficits, and then helps you wean off steroids faster. What are the differences between surgery versus gamma knife for radiosurgery is that the SRS is basically, it helps you treat small eloquent lesions. It helps you treat multiple lesions in small durations. It's minimally invasive compared to surgery. And there's a thing of potentially avoiding whole brain radiotherapy. The question is whether you will treat a single metastasis or whether you'll treat multiple metastases in the same way. Whether you treat small metastasis or more than 2 centimeter metastasis in the same way. How much radiation would you give? Would you fractionate it or not? And whether the treatment for radio-resistant and radiosensitive metastasis varies. Of course, for the single metastasis, we have already discussed surgery if there is mass effect and radiosurgery if there's no mass effect. So what do you do if you have 1 to 5 metastasis? And if you see historically, whole brain radiotherapy was the treatment of choice, while SRS is coming up newly and it delivers high dose radiation only to the visible brain metastasis. But the main disadvantage of whole brain radiotherapy, which has been the significant neurocognitive side effects. And so this raised a question as to whether surgery should be offered. Is whole brain radiotherapy actually necessary? Does it offer any benefit vis-a-vis SRS? Would you use radioprotective techniques? Can you use SRS alone as a treatment modality? And is there any difference in both the recurrence-free survival as the overall survival in SRS versus W-brain therapy? So the first question, the question is, should radiotherapy be actually offered to patients with metastasis? And there have been a sort of general consensus that if your KPS is very poor, and if you have no systemic therapy options, then probably it's better not to offer radiotherapy at all. But again, in this subgroup, there have been improved survival associated with whole brain radiotherapy for subgroups with better prognosis, such as greater than, say, 60 years old patients. This again is because of the side effects of whole brain radiotherapy, of which neurocognitive decline is the most significant, but it also has other side effects such as somnolence, alopecia, fatigue, skin erythema, otitis, radiation necrosis, and leukoencephalopathy. And this neurocognitive decline has been found in almost 11 to 15% of patients who underwent whole brain radiotherapy. They generally occur 3 to 4 months after treatment and has been the destruction of the hippocampal cells. To prevent this, there have been studies and in which memantine has been used to slow down the cognitive function. And also newer techniques such as hippocampal sparing has been associated with less severe impairment on some neurocognitive tests. And the RTOG 0933, which is evaluating neurocognitive performance, the results are pending. So generally, the whole brain radiotherapy is falling out of favor in 1 to 4 metastases. And now more or less it's been limited to patients who have diffuse leptomeningeal disease or too numerous to count metastases or very poor KPS where it's used as a palliative treatment. And if you're giving whole brain radiotherapy, it's important to consider to use memantine, which is an NMDR antagonist, and also consider hippocampal sparing radiation as shown in this diagram. With a less than 5% metastasis in the hippocampal area, but still you need to use a hippocampal sparing radiation. So the greatest advantage of radiosurgery is that, of course, apart from it being non-invasive outpatient procedure, there's no requirement for local anesthesia, is the fact that you get a very good conformality index, especially with gamma knife. And if you see this clearly, the red line is this is a gamma knife plan. The red line is the tumor outline, the yellow line is the 50% isodose line, and the green line is the 20% isodose line. So if they were giving 20 grays over here to the margins, this is around the 10 gray line. So you can see that the rapid fall off of the dosage from the tumor into the surrounding brain. So the conformality is very good and you can give a greater dose of radiation to a smaller area. And metastasis is very ideally suited because if you see, unlike a glioblastoma, which has infiltrates into the white matter and it's very difficult to target and frequently reach larger sizes, brain metastasis has quite a sharp demarcation from the surrounding tissue. And even if you go for a few millimeters, you still get a 45% dose of the central dosing to the radiosurgery periphery, which still is good enough for many of these metastases. So we use the gamma knife in our center, and with the new icon and the perfection, we can do both a stereotactic frame fixed SRS, or we can use the mask based, which is also available on the LINAC based machines. So both of them, we do the volumetric MRI on the 3 Tesla or the 1.5 Tesla as mentioned by Professor Mukherjee, then do a CT, merge the images and treat metastasis. So coming back to the role in 1 to 4 metastasis is that the Andrews et al. Showed that SRS boost to whole brain radiotherapy does not increase overall survival. But SRS added to whole brain radiotherapy improves local control. And there have been multiple class 3 studies which says that it is safe and effective to use focal radiotherapy to improve local control. And Chang et al. Said that if you withhold WBRT in favor of radiosurgery alone, you have improved neurocognition, survival is more or less the same, but has decreased on local and distant control. IOMA, where they compared SRS versus WBRT plus SRS, there was no difference in the two groups in terms of OS, but the local and distant failures as well as salvage therapy was significantly lesser in the WBRT group. While one of the studies was stopped due to increased neurocognitive whole brain radiotherapy. So one of the main concerns raised in all these studies was the fact that there are going to be local distant failures that is the occurrence of metastasis in other sites in the brain if you do not give whole brain radiotherapy. But if you give whole brain radiotherapy, there's going to be an increased neurocognitive outcomes, worse neurocognitive outcomes. So what are the recommendations by Astro is that SRS is definitely an option when the overall volume of lesion is clinically determined to be small. It can be added in multiple metastases only if you have leptomeningeal enhancements and to improve local and distant control. But more or less in 1 to 4 metastases, what has happened is that there has been a shift to use SRS alone, defer the use of whole brain radiotherapy as a salvage regimen, and do serial scans. And if there are going to be fresh lesions elsewhere in the brain, you again treat them with SRS. So you increase the surveillance, and any new and emerging lesions can be treated with repeat dose of gamma knife or SRS. So what this does is it takes away the problem of recurrence, because you are doing frequent monitoring with serial MRIs, and also decreases the neurocognitive effects, which is a significant problem with whole brain radiotherapy. So what happens if you have more than 5 metastases? There have been multiple studies again in which SRS had, which has shown that SRS had greater mean survival time, higher freedom from neurological death, and higher quantitative survival. SRS can effectively treat 5 or more metastases at any time, and SRS alone without WBRT provides excellent survival in patients with 1 to 10 brain metastases. So basically, what all these studies have shown is that the results of 1 to 4 metastases have more or less been replicated with 5 to 10 metastases. But even though we have had good quality studies in the 1 to 4 metastasis group, the quality studies are not still available in the greater than 5 metastasis group. There is one large study by Yamamoto et al. From Japan in 1194 patients. They showed that between single metastasis and multiple metastasis, there was a significant survival difference, but the number of metastases, if greater than 1, did not affect survival. Non-inferiority of stereotactic radiosurgery without WBRT with 5 to 10 metastases as compared to those with 2 to 4 tumors. So it basically means that even though it is not a good control, there is non-inferiority of stereotactic radiosurgery. And considering the neurocognitive effects of WBRT, SRS provides equivalent local control without changing overall survival with respect to WBRT. And the EORTC study also showed that like 1 to 4 metastases, while WBRT reduces intracranial lapses, it does not improve the duration of functional independence or survival. So basically what this whole thing means is that what is happening in 1 to 4 metastases, the same thing is happening with more than 5 metastases. So what are the current status for greater than 5 metastases as per the Astro recommendation is that evidence is limited to retrospective studies, so therefore it's not a good quality evidence. But in selected patient population, there is no difference in overall survival if you compare SRS alone with WBRT with SRS for multiple metastases. So a consensus in a poll of majority physicians attending radiosurgery meetings, they consider it reasonable to treat 5 or more metastases with SRS despite lack of RCTs due to the significant neurocognitive defects associated with WBRT. And also because SRS, the ease of delivery and the improved systems means that more facilities are available and SRS can be used frequently, and they make up for the lack of increased relapses in other sites by doing frequent imaging and retreating them if necessary. The other question is how many metastases is too much? Whether you treat with 20 metastases, 40 metastases, 35 metastases, 20 metastases, we don't know. So because the cumulative volume of metastasis is more important than the absolute number of metastases, so the number of metastases has been taken away and the cumulative volume is more used to decide whether the patient can go in for SRS or for whole brain radiotherapy. For example, this patient with multiple metastases, if you can see, she's almost had 16 metastases, was treated. And if you can see the number of metastases, incidentally, the patient also has a cavernoma in the right basal ganglia. So this is the cavernoma here, but you can see the number of metastases over there. And all of them can be treated because the cumulative tumor dose is within limits. And this is the post after 3 months. You can see there's been a decrease in the metastasis. So there have been studies on this as to whether new metastasis after gamma knife surgery, what happens to them. So in this, it says that while new metastasis did develop in 50% of the patients, additional gamma knife was extremely effective in controlling disease, and fewer than 20% actually required whole brain therapy, and the majority died due to the progression of neurological disorders. So coming to the third point, delivering radiosurgery. Would you use a gamma knife or a LINAC-based system? I think multiple centers around the world use either of them. There has been no significant difference between the outcomes. But the gamma knife system does have a lesser error of 0.48 millimeters compared to around 1.5 millimeters of a CyberKnife system. The conformity index is better, 1.17 versus 2.7 to 2. And the other important thing is because you're going to treat a large volume in multiple metastases, the extracranial dose is significantly less with gamma knife compared to the CyberKnife. The other question which we've had to answer is, does single dose SRS have the same effect as 3 to 5 fractions? This is because what happens is as the volume of the brain metastases increase, you will have to get the dose down. So, and what happens is if you get the dose down to 15 grays or 18 grays, the control loads drop from 85% to almost 49 to 45%. So can you give a dose equivalent of around 20 to 22 grays by fractionating it in 3 to 5 fractions and then delivering it? So this is something we don't know, but many centers, including ours, where if the total volume exceeds around 12 grays, 12 cc, we tend to fractionate it and give it over 3 fractions and give a biological equivalent dose of 20 to 22 grays for metastasis. So most centers use at least 18 grays, we use around 20 grays. And the reported local control rates in multiple series have varied from 70 to 95% in various types of malignancies, regardless of whether they have been traditionally considered to be radio-sensitive or radio-resistance. And this again shows the same graph in which higher dose decreases the local failure. This is what I mentioned. What happens if there is larger brain metastasis? One is, of course, fractionating the dose. And the second thing is to give 2 doses spread over 3 to 4 weeks. So this was a study by Angelov et al., in which they treated metastasis greater than 2 centimeters in diameter. And what they did was, in the first stage, they gave 15 grays, did an MRI after average of around 30 days, and then marked the tumor and gave another 15 grays. And they found that between stage 1 and stage 2, the tumor had actually shrunk by around 30%. So they were able to treat smaller volumes at the second stage, and they had an excellent overall local control of around 88%. So these are similar studies. So these are the various strategies available, whether you can do it in a single session, you stage it over weeks, or stage it over, fractionate it over 3 to 5 days. We still don't know the answer, but this was a paper published by Angelov in which they showed that this was the metastasis treated stage 1, it had shrunk in stage 2, and over a period of time, it had significantly decreased in size. So coming to the role of SRS with immunotherapy, of course, immunotherapy has been used in multiple patients. I will not go into detail because mine is about radiotherapy, but the inhibitors, immunotherapy drugs have been used in melanoma, HER2-positive cancers, and NS, non-small cell lung carcinomas. And they act basically because of the abscopal effect, where the systemic immune response is activated and the primary tumor gets irradiated and releases the tumor antigen in the blood. So it's worthwhile using immunotherapy if the tumors happen to be responsive to them. So finally, I'll come to the recommendations, which is a summary. The first recommendation, it should not be offered to patients with asymptomatic brain metastasis who have KPS less than 50 or a KPS 70 but no systemic therapy options. SRS alone should be offered to patients with 1 to 4 unresected metastases, excluding small cell carcinomas. It should be offered to patients after surgery also to increase local control. For greater than 4 metastases, SRS, WBT are a combination of all reasonable options. There's no hard data to differentiate between them as which is good to which is bad. But of course, you have to remember that WBRT has a higher incidence of neurocognitive decline, though that has come down with hippocampal sparing techniques. Again, if you're using whole brain radiotherapy, you should use memantine and hippocampal avoidance, especially if the expected survival is long. And there is no evidence to support the use of radiation sensitizing agents in these patients. So I would like to conclude by saying that models do exist to understand median life expectancy for metastasis. It's not a bleak future. The role of steroids should be constantly evaluated, and the faster you taper off steroids, the better it's for the patients. Surgery has a role in large symptomatic brain metastasis. Radiation is required either as a pre or the post, as mentioned by my previous speaker. Metastasis is a very typically ideal target for gamma knife. Whole brain radiotherapy increases cognitive decline and should be used in selective circumstances, which is constantly coming down, and you should use memantine and hippocampal sparing techniques. SRS dosing is based on the tumor size and the volume. You can consider multiple stage SRS for tumors which fit into those criteria, and you can use both frame and mask options for these metastases. Thank you.
Thank you, Dr. Dwarakanath, for giving lucid and clarity on how to go about brain metastasis, depending on, it's not the numbers, but the volume also is important. And the follow-up with the proper investigation also will decide what kind of treatment to be done. There are some questions in the chat box you have to reply. As we are short of time, I'll request the next talk by Professor Karaka from Istanbul. She is the head of the Department of Medical Oncology at Turkey, and she'll be speaking on immunotherapy in metastatic lung cancer as well as in melanoma.
Hello all. Actually, I'm from Izmir, Ege University Faculty of Medicine, where Professor Zilali is also from. And thank you for the invitation and thank you for the great introduction. Today, I'm going to speak on the systemic management of brain metastases. And actually, we have some words to say as medical oncologists, beginning from the 2010, because before that, we didn't have any effective drugs to control the brain mets, but now we do. So as a result of improvement in the systemic cancer therapy, and higher resolution and greater frequency of brain imaging, brain metastasis incidence is increasing in the last years. Within all type of cancers, brain mets are the most common in lung, breast, and melanoma patients. So the first cancer I'm going to talk about is melanoma because it represents about 12% of all patients with brain mets. Nowadays, targeted therapy and more immune checkpoint inhibitors are used successfully to treat advanced melanoma. That's what we know. Combi-AB, which is the combination of dabrafenib trametinib, is the first randomized clinical trial to show efficacy of targeted therapy in melanoma brain mets. The most common type of BRAF mutation is BRAF V600E in melanoma. However, this study also included very rare mutations like BRAF V600D, K, and R mutations. This study demonstrated the clinical utility of BRAF MEK inhibitors in which patients who had BRAF mutation, and it's about 40% of the all advanced melanoma patients with asymptomatic or symptomatic brain mets, and it had an intracranial overall response rate of 44%. Unfortunately, leptomeningeal metastasis was excluded from the study, so this clinical phenomenon stands as a huge clinical challenge for us. So when we look at the response patterns of the COMBI-MB trial, there were 4 cohorts. The cohort A are the asymptomatic patients who have not received any local therapy before. Cohort B patients, asymptomatic brain mets, again, who had received some local therapy, mainly radiotherapy. Cohort C are the patients with rare BRAF mutations, BRAF DKR, and cohort D are the ones who are symptomatic with rare mutations. So what we see here, the best overall intracranial response that we see is 44%, and there were some CRs actually in cohort A and cohort B, and of course in cohort C and cohort D are less in response. So, but what's more important is what is the intracranial duration of response in this trial? It is not very high in regarding to mounts. It's around 46 mounts approximately. So that's far less than what we see with the immune checkpoint inhibitors. So as a result, COMBI-MB trial clearly demonstrated us there is an intracranial activity of dabrafenib plus trametinib in melanoma patients. However, from a practical point of view, cerebral disease is not really controlled in nearly half of the patients, which still represent an unmet clinical need. And we should also keep in mind leptomeningeal metastasis is not really included in the study, and most complete responses were achieved in patients with 1 to 2 brain metastases, which are also effectively managed with surgery or stereotactic radiosurgery, as the previous speaker had already pointed out. So later on, new clinical trials with immune checkpoint inhibitors were done in the era. And this had some very flashing results, actually. First trials were using immune checkpoint inhibitors as monotherapy, mainly anti-PD-1s as monotherapy, whereas the recent clinical trials were using immune checkpoint combinations. So when we look at the long-term results of the CheckMate 2 or 0 trial in patients with active melanoma brain mets treated with the combination nivolumab plus ipilimumab, that's mainly an anti-PD-1 plus anti-CTLA-4. When we look at the results in asymptomatic patients, which were high in number, there were around 33 over 30% of complete responses in the intracranial area, so which is quite astonishing, actually. When we look at the symptomatic patients, of course, it's low in number, only 18 patients, but it's very striking for us to see there were also some complete responses with the EP-nivo combination in this arm again. But what is more important here is when we look at the duration of response, this matters, this differs from the ones that we see in the COMBI-MB trial. As you see, the ongoing responders are the ones, patients with the objective response, and it's over 85%. So this is very important. The ones who have already responded to the combination immune checkpoint inhibitor do live longer and do not really show up with any more brain mets. So then came the ABC study and changed a lot, actually. This was a real game changer for us. This was a study by Georgina Long from the Australia Cancer Center. Melanoma brain metastasis over 5 millimeter up to 4 centimeter, up to 5 metastases were allowed. No previous anti-CTLA-4, anti-PD-1, anti-PD-L1 agents, no immune checkpoint, this means. But previous BRAF/MEK is allowed. ECOG performance status might be up to 2, which is very rare actually in clinical trials. No serious autoimmune disease, no corticosteroids. So it's a 1-to-1 ratio up to 51%. The cohort 8 included no prior local brain radiotherapy, asymptomatic patients. There were 35 patients, nivolumab plus ipilimumab. When we are talking about here, ipi is the high dose ipi. And cohort B included no prior local brain radiotherapy, asymptomatic patients, and they received only nivolumab, anti-PD-1 monotherapy alone. Then they added another cohort, cohort C. This is actually a group of patients with a very bad prognostic features, previously treated or symptomatic or leptomeningeal spread with MRI progression, and these were treated with nivolumab alone, and there were 16 patients in this arm. So primary endpoint was the intracranial response, but secondary endpoint, overall response rate, PFS, and overall survival. When we look at the EBC patient characteristics, it's a well-balanced actually trial, and mostly the patients were in good health shape, ECOG performance status either 0 or 1. Around 55% of them BRAF mutated, but when we look at the bad prognostic arm, which is the arm C, there were 81% of them with BRAF mutation, because this is what we know from melanoma. People with BRAF mutant melanoma have worse prognosis. And targetable brain mets, over four brain mets, were around 40% in the cohort A, 20% in cohort B, and over 50% in cohort C. So prior BRAF MEK inhibitor usage were around 25% in cohort A and B, but when we look at the cohort C, it's 75%. So heavily pretreated, we can say. So when we look at the intracranial RECIST response, so we can easily see that the cohort A, asymptomatic patients who received nivo-ipi, no local brain radiotherapy, had an intracranial response of 51%, and complete response of 26% actually. When they look at the nivo arm alone, we see that it's much less effective. And when we look at the C arm with leptomeningeal mets, symptomatic, and who had received already local radiotherapy, so we can see that 6%, around 6%, there is only in one patient intracranial response, and that's negligible. That's what I can say. So in the drug treatment naive patients, this means the patients who have not received any treatment before, no BRAF MEK inhibitor, nothing. So when we look at these results, then the cohort A, we can see that the results have already increased regarding the intracranial response and also complete response. The complete response is 30% in the nivo-ipi arm, and it's 16% in the nivolumab arm. Progression-free survival is very striking here because, as I studied before, when you are applying ipi-nivo combination for patients with brain mets, the one who have already responded do live longer. You can see these are the mounts. It's very interesting because we are talking about melanoma brain mets. So we can see that after 60 mounts, around 50%, 46% of the patients who had brain mets are still living. These are the patients treated with ipilimumab, nivolumab. But when we look at the other cohorts, of course, when we treat the patients with monotherapy, only 15% of them are living, and the ones who had already symptomatic brain mets, leptomeningeal mets, the bad prognostic factors, only 6% of them are alive at the 5-year. So when we look at the drug treatment naive arm, the numbers are a little bit better for them, but it's around 50% again. So we can definitely say that using ipi-nivo and ipilimumab in the higher dose for these type of patients is the new standard of care for melanoma. Any subsequent therapy after intracranial progression, of course, most of them stereotactic radiotherapy, local therapy. Some of them had surgery, of course. And when we look at the systemic therapy, mostly the BRAF/MEK was chosen if they didn't receive it before. But of course, chemotherapy was also applied, about 11% of them. Yeah, overall survival we can also see from here. So when we look at the conclusions, nivolumab, ipilimumab has enduring activity in patients with untreated asymptomatic melanoma brain metastasis, no prior local therapy or BRAF/MEK inhibitors. These results are similar to the studies of ipilimumab and nivolumab in patients without active brain metastasis. Long-term survivors had a numerically higher proportion of patients with lower burden of extracranial metastasis as expected, normal LH and ECOG 0 at baseline, and of course, no new toxicity was observed with the long-term follow-up. We now know these drugs very well, and we have been using it over 10 years now. Although when we come to breast cancer, this was the melanoma story. When we come to the breast cancer, all breast cancer subtypes are at risk of developing brain mets. But of course, the incidence is the highest for patients with triple-negative breast cancer. It's around 50%, and HER2-positive disease, it's around 30%. For HER2-positive patients, lapatinib and tucatinib, these are two anti-HER2 drugs working intracellularly, have the modest intracranial activity as monotherapy. It's around 10%. But their intracranial activity increases when they are used in combination with capecitabine. Capecitabine is the oral form of 5-FU, and it has a high penetrance through the blood-brain barrier. So the combination with the combination treatment response goes up to 30%. But HER2CLIMB trial searched for the answer of the addition of tucatinib to trastuzumab capecitabine combination in patients with brain mets. Trastuzumab is the anti-HER2 drug, but it acts as a surface on the surface. Tucatinib works in intracellularly, actually. So addition to tucatinib, according to the HER2CLIMB study, addition to tucatinib to trastuzumab capecitabine improved overall survival as compared to the placebo group in this group of patients. It's around 25 months versus 19 months in over 600 patients. But more recently, there were some newer drugs on the shelf, new kids on the block, to treat these types of brain mets in HER2 positive breast cancer. And antibody drug conjugates have shown really great efficacy in controlling brain mets in HER2 positive breast cancer. So Destiny-01 is a study which has evaluated trastuzumab deruxtecan. This is an antibody drug conjugate in patients with heavily pretreated, around 2 to 3 cycles of treatment before, lines of treatment before, with HER2-positive disease. And among these, there was a subgroup of 24 patients who were treated for brain mets. In this group, overall response rate, intracranial response rate was 59%, and median progression-free survival was 18 months. So we can now say that trastuzumab deruxtecan is the new standard of care for this group, especially for patients who are asymptomatic. For triple-negative breast cancer, actually nothing really much happened on the systemic treatment side concerning brain mets in particular. So local treatment options should be the first to choose in this group. Of course, for neoadjuvant treatment, adding pembrolizumab, which is an anti-PD-1 treatment, is a real game changer when we're talking about locally advanced triple negative breast cancer. But unfortunately, immune checkpoint inhibitors didn't show great efficacy in controlling brain mets in triple negative breast cancer group. So let's pass to the lung cancer, but let's pass to the lung cancer, which is ALK positive, because ALK positive breast cancer, lung cancer is a special subgroup. ALK positive lung cancer patients represents about 5% of the all non-small cell lung cancer, but in approximately 40, sometimes in 50% of those who present with brain mets. So new generation ALK inhibitors, ceritinib and more likely lorlatinib, have demonstrated intracranial response rate of up to 50% in this group of patients who have already progressed on chemotherapy or first generation drugs like crizotinib. So we can now say that for patients with ALK positive lung cancer with brain mets, lorlatinib or ceritinib, lorlatinib we have in Turkey actually, lorlatinib is the new standard of care for this group of patients. What about for EGFR positive non-small cell lung cancer? EGFR positivity is around 15% and mainly women who are non-smokers. Currently, osimertinib, which is a TKI inhibitor again, is recommended for those with asymptomatic brain mets. And actually, increasing the dose of osimertinib from 80 milligrams to 160 milligrams might also control some leptomeningeal metastases, which is a very important and a clinical challenging topic for us. So we may escalate the dose in some of those patients who have EGFR positive metastatic non-small cell lung cancer. Last but not least, it's highly recommended that patients with brain mets who are candidates for systemic therapy that have demonstrated intracranial efficacy should be discussed in a multidisciplinary tumor board to determine the optimal integration and sequencing of these therapies. Not everybody needs surgery, not everybody needs radiotherapy now. I have a very short case. Sorry, this is in Turkish, but I'm going to just translate it. This is a 46-year-old male patient which had a melanoma on his right forearm, and the pathology revealed as this superficial spreading melanoma, breast lobe over 5 millimeter, ulceration positive, and mitosis were there. Actually, no sentinel lymph node invasion was there, and he was on the follow-up, and 3 years later, he developed both in a left axillary lymph node and together 2 mets in the brain, one 10 millimeter, one 7 millimeter, and the patient was asymptomatic. The mass in the left axillary was very hard and very fixated. We did a TrueCut biopsy and was shown melanoma metastasis with BRAF V600E mutation. And of course, we started, according to the ABC trial, we started with the EP high dose and Nivo 1 milligram per kg. And after 3 cycles, he couldn't afford the drug anymore, but we did a cranial MRI and we saw that, of course, there was a complete remission of the lesions. You can easily see it here. Now he's doing very well after 12 years of treatment with a immune checkpoint inhibitor combination. So this is what I would say. Thank you for your patience. And I'm ready for the questions, actually.
Yeah, thank you, Professor Karaka. Then for highlighting that immunotherapy, once immunotherapy is very popular, maybe neurosurgeons and radiation oncologists are not needed because everything can be treated with immunotherapy.
Not really. We do still consult patients with radiation oncologists and neurosurgeons, of course.
Yeah, thank you. Because we have a session to follow, We have to cut down the questions. I'll request Professor Jalali to give a concluding remark and start the next session. Professor Jalali.
Hi. Yeah, it was a great seminar, actually. I thank all the speakers for their very valuable contributions. Also, our friend Burçak from Izmir did a very well talk. I think shall we stop here because the other symposia should start.
Yes, please.
Yeah.
We can stop and start the next one.
Yeah. Thank you all for their very nice talks. And we will start now the WFNS Education Symposium number 13. It is on endoscopic spine surgery. And we will try to answer the question, is it the new standard? I call Dr. Hyun-Sung Kim, he's with us, to moderate the session. I think Benedict did not join us yet.
Okay, hi everyone. I'm Hyun-Sung Harrison Kim from South Korea. This session is a WFNS Education Symposium 13, and the title is the endoscopic spine surgery. Is it the new standard? And we have a full lecture program of the endoscopy with the tube Jayashi Sharidhara and the posture with the water irrigation system by Jose Lame Guerra, and endoscope fusion by me, and the final future of spine endoscopy by Benedict Bukrahart. And now we will start the first lecture from Jayashi Sharidhara for endoscopy with the tube. Jayashi?
Yes. So thank you, Dr. Kim, for I would like to thanks WFNS committee, Dr. Zeli sir. Thank you for this opportunity. Good evening, Dr. Mana sir. I'm going to share the screen.
Please share your screen, yes.
Am I visible? Yeah, my screen is visible.
Yes, we can see your screen.
Okay. So my topic is endoscopy with the tube. Just a second. Yeah. So in this, just a second, something. Hang just a second. Again, I'm sharing stop. Sharing the screen. Stop. My screen is not visible, right?
We can see your screen, but we can. Okay, your screen disappear.
Just give me 1 second. Okay, so here it is. So my topic is endoscopy with tube, and in this 21st century, it is an era of minimalism, and the world is trending from open spine surgery towards endoscopic spine surgery. And of course, we all know that there are a lot of advantage because of open surgery to minimal invasive spine surgery. I believe that the spine endoscopy should start with lumbar L4-5 or L5S1 disc, mainly towards the left side. We should choose a lean and thin patient. A lot of advantage for that. Gradually, after 30-40 cases, we should move towards the next step, that is a canal stenosis as well as lumbar fusion. And after we more become confident in the spine endoscopy and three-dimensional anatomy of the spine, then we should at the end move to the cervical PIVD and stenosis at the end of the curve. This fantastic system, this tube is called Destando tube, and it's developed by Jean Destando. I do all the spine procedures with this. So this is the system, and there are three tubes in this instrument. One is obturator, so outer cannula, and this is the inner cannula. So it's almost 1.8 centimeter tube. It's require almost 1 centimeter to 1.2 centimeter in this. Now this inner cannula has 4 channel. One is for success, this working channel. This small one is for this for nerve hook, and we can call it nerve retractor. There is a 4 millimeter endoscope channel. Normal 4 millimeter 0 degree endoscope is being used for a Destando. That is the most important part. We doesn't require a new endoscopy system to buy, more economical. 4 channel is for suction. Any normal available suction can be used. And so this is the system. Position. Usually there are two kind of position. I do all the endoscopic discectomy in the lumbar flexion. So either you open the Wilson frame, it open the interlaminar and foraminal space and need less and less bony decompression. This is the advantage. So this position is required for endoscopic discectomy. Another position, which is lumbar lordosis. So I do all the canal stenosis, decompression, and fusion and fixation in normal natural lumbar lordotic position, because it facilitates the decompression as well as fixation in its narrowest dimension. So patient have a maximum advantage of that. So the incision is more standard, just 1 centimeter lateral to the spinous process. Our tube should be exactly targeting the upper lamina. Suppose I am going for L4-5 discectomy, I supposed to target on L4 lamina and L4 spinous process while docking and marking. The marking is very important. So this is first step is you go subperiosteal to the spinous procession after incision. You dock this obturator and outer cannula exactly over the L4 lamina. And I use two cotton patty, that is we call it peanut. One at the upper edge of the lamina and the other one at the lateral to the facet, facet joint. So this two peanut or gauze piece prevent the, because this is the advantage of Destando system is highly mobile system. That is advantage also, but the disadvantage is muscle can be popped out. So by this method, I can avoid all muscle creeping and popping inside my endoscopy field, and the view will be very, very clear. So after I dock the tube, this is the endoscopy picture. This is a 46-year male and who has a right side radiculopathy and there is a EHL weakness. So I'm doing L4-5 endoscopic discectomy. So the docking, you should start with the L4 level. So here is the L4 lamina, and the 6 o'clock is the facet. So the standard lower half of upper lamina should be drilled till we reach the ligament of flavum insertion, then ligament of flavum being removed, and 10 to 20% undercutting of facet is required for drilling. You can see there how much drilling, only just a few millimeter of upper lamina supposed to be drilled. And we expose the dura, the ligament of flavum supposed to be carefully excised through punch. Now the lateral limit of dissection or facet drilling is you're supposed to see the lateral edge of nerve root. Here is the L5, right? L5 nerve root. It should be very, very clean picture, and the lateral edge supposed to be seen free without any retraction. Now I use two cotton patty, one exactly here at the shoulder. In the shoulder of the nerve root, I push beneath the lamina so that there are two advantages. One, we can retract the nerve root. Second thing, it's also prevent a soiling of blood, and your field should be very clear. So this will help. It's also control the epidural bleeding. So two cotton I use. One is above shoulder and one is at the axilla. And here I am retracting the nerve root, and there are another instruments called nerve retractor which we can place. We can see that this system is very mobile. So exactly where, whatever the angle you want to work, you can work, and you can decompress all the four corners of that spine. So this is retracting nerve. This is the disc prolapse exactly at L4-5. Now I'm going to coagulate it. There's a bipolar used for decompression, and you can see that I am using all normal instruments we are using for other normal surgery. So after discectomy, all the high pressure disc degenerative part is coming outside. and that part is excised. So we can see not only the ipsilateral root, but even in fact the contralateral root is also get free. So you can see the endpoint is very, very clear from starting from shoulder to axilla. So another patient with 35 lady here, I want to say it's a pre-op image. She has a right side S1 radiculopathy and post-op hemorrhage is very clean. And so after annulotomy, we can see all the extruded part. Only I remove only the extruded and degenerated part of the disc. Other annulus I always coagulated. Now for canal stenosis, it's very, very important. It's a 52-year lady, 52-year female, and had a neurogenic claudication and second of only 100 meters. You can see there is a severe canal stenosis. It's also important while you remove the hypertrophic ligament of fleum, not only the dura. If you break the base of the spinous process, and you can also get the entry to the opposite contralateral superior facet, and you can decompress the contralateral nerve root going into the foramen very well. You can see the contralateral nerve root in the foramen. You can see the ipsilateral nerve root in the going into the foramen. These are the three important point and place where you decompression is important. Otherwise, there will be a residual stenosis. So this can be possible by a single small incision, contralateral, just base of spinous process supposed to be drilled. Now, most common complication of the endoscopy with the tube or other minimal invasive spine surgery at the lumbar level is a CSF leak, and commonly happen while you are removing the chronic ligamentum fleum hypertrophy, particularly while separating from the dura. Without separating the dura, there will be a leak like that. So my principle is very clear. If there is only arachnoid prolapse, I do nothing. If there is a nerve prolapse and there is a gross CSF leak, usually I keep it inside by some dissector, and I use artificial dural page. Very occasionally, rarely it requires suturing, but it's absolutely fine. Like this kind of artificial page is required. Now, few slides for cervical spine endoscopy. So out of all the options available for the cervical PIVT surgical option, I'm telling the conventional treatment of fusion surgery, and the now world is trending toward the motion preservation surgery. So if you compare the SCDF and artificial disc replacement, if you have option of posterior approach like posterior cervical discectomy and foraminotomy, this is the fantastic because it doesn't require any instrumentation, preserve the motion of the cervical spine, which is very, very important. Anterior indication of cervical spine endoscopy, which can be do with the tube also, is the SCDF and artificial disc replacement. Posterior approach, the indication are a young patient, unilateral, soft or hard disc, which is compressing the one side of nerve root like this at C45 and C5, C6 prolapse. This require endoscopic lamina foraminotomy. You can also operate a multiple level of compression, compressive cervical myelopathy at 2 or 3 level by the single incision by posterior where it is indicated. And you can also approach a cervical IDM, small size on one side. In the young patient, this is indicated by endoscopy. Now, very, very important point, if you are doing the posterior endoscopic of cervical approach, where do you dock the tube? So your tube is docked exactly at the V point. So where is the V point? So the adjacent lamina, superior lamina, this is the inferior lamina, where it is meet at the apex. This is the facet joint, and this is called V, where exactly you're supposed to dock the tube. Now, idea of lamina foraminotomy is you convert this V into U. So for that you require upper and lower half of laminotomy and 20% of 10 to 20% of facet joint. So this require for 1 level decompression. For 2 level decompression, you require 1 full lamina and upper or lower half of half lamina for 2 level decompression. For 3 level decompression, you require a 1 full lamina and adjacent upper and lower half lamina through only a single incision. Now, what is the difference between a lumbar and cervical spine endoscopy? It's a very important point. While you are doing the cervical spine endoscopy, the nerve root lies in the lower 1/3 of foramina, unlike the lumbar spine, which is the upper 1/3 of foramina. It means that while you are decompressing, the nerve root is not going away from you, rather nerve root will come towards you. So this is very important that you know you are decompressing the nerve root which is coming toward to you, that you need to decompress. The other part is the vertebral artery. The dam, it is lying just at the entry point, targeting point, that is the lamina facet joint. So you have to work medial, medial, and medial. Other important landmark point is up to C4. You can see that all the V points overlies the nerve root crossing. It is very easy to find the nerve root. But at the C5, C6, and C level, because nerve root overlies, dura, and more course will be oblique. So V point will going far away. You may require more variable facet joint drilling, sometimes 10%, sometimes 20%. But remember that 50% of facet joint on one side, other side can be drilled without, you don't require stabilization for that. So the posterior approach, the incision would be 1 centimeter lateral, exactly at the level, exactly at the lamino facet point. And you have to do some little bit neck flexion, so they open the foramina. This is the tube used. Then you put an incision subperiosteally, you apply this obturator and outer cannula, you look at the CM, you confirm it. And after you enter the scope, this is for single level C5, C6, right side for aminotomy and discectomy. So here is the V point. This is cranial C5 lamina, C6 lamina, and this is a facet joint. And we can see here, this V supposed to be make it U by drilling the upper and lower half of lamina. And facet supposed to be drilled, the ligamentum flavum should be excised. Now, few things is important in the while you are operating the cervical spine. One, there will be a bleeding which is more. It can be controlled by only gel form or something called flow seal or surgery flow. Second thing, that now supposed to be, you cannot retract the cervical cord or thecal set like in the lumbar spine. This is the disc, the soft disc which is compressing the junction of the V point. You can excise here. Now, an idea is not to just a discectomy, but idea is to decompress the nerve root at 360 degree. For that, you have to decompress superior, inferior to the nerve root. Beneath the nerve root, you have to drill. If there may be any osteophytes or soft discs, you have to remove like this. So here, the osteophyte has been removed, and the lateral margin, the nerve should be very freely pulsatile like this for one level. Like this patient, there's a 28-year male with this disc collapse C5, C6, and we can see the lateral limit of disc, the decompression is that it should be the lateral edge of foramina exiting, this nerve root exiting point. So you have to drill like you are undercutting of the facet joint, and it should be 360 degree free. You can palpate, you can feel the freeness by dissector putting inside. So this is the end point of the laminoforaminectomy. Sometimes I started for 2-level cervical discectomy. This is a patient with severe right side radicular pain, C4, 5, and C5, C6 foraminal stenosis. If you want to do a decompression by a single level, you can leave this kind of island lamina, and you can decompress both the level through a single incision. And you can do a 2-level foraminectomy through a single incision. For multiple level decompression, so this patient was priorly fixed with the anterior cervical fusion and 2-level, there was compression, so I decided to go from back because it is already fused anteriorly. For that, you have to dock exactly over the lamina, but not in the V point. And then you drill the lamina gradually. Whole lamina is supposed to be decompressed. Look at the mobility of the cervical spine. In the single level, you can decompress up to 3 levels. And bleeding is very common problem in the cervical spine. For that, you need to I just put a gel foam beneath the lamina, and it make my walk. Sometimes I also require a flow seal or surgery flow for that. Yeah. So like a lumbar vertebra, lumbar spine endoscopy, the base of the spine is supposed to be drilled, and it will good enough that you can also decompress the opposite side also like lumbar spine, like same. So this is the completion of 2-level lumbar decompression. The patient with a 3-level compression, the single incision, it also helps to decompress at the 3 level. You can see here, this is the incision. So 3-level also can be decompressed with a single incision. Okay, so you can see the level of bony decompression, 1 level, 2 level, and 3 level. So midline spinous process is intact, your facet joint is intact. So it is obviously stable. so it doesn't require any instrumentation. The literature says that the anterior and posterior approach, the discectomy and ACDF have the same clinical response. And 5-year follow-up, even you can decompress cervical lordosis less than 10 degree, and 5-year follow-up says there is no progressive kyphosis even after 5 years. Because you are using endoscope, the only facet drilling is required is 10% compared to 30% with other procedures. Other indication is IDM. The single level IDM can be easily decompressed with this kind of tube. So at the nutshell at the end, the endoscopic discectomy and decompress is one of the good alternatives with equal clinical outcome and better edge in motion preservation in patient with a single or multiple level cervical disc condition, canal stenosis, in which posterior approach is indicated. Because with a single level, you can decompress at the 3 level. At the end, for all the spine endoscopy or miss, please remember that incision doesn't make it miss neither tube. Rather, if you don't have anatomy knowledge, it may make you a miss because it's all the radiology. It's a technology dependent. So understanding of the 3D anatomy, the preservation of bony and soft tissue anatomy, and meticulous dissection hemostasis is the key for the spine endoscopy. Thank you so much for your attention.
Thank you so much, Dr. Jayeshi. And there still have no question. Maybe if you have any question, please writing on the message to here. And I have a question that maybe your technique may be some different with some tube conventional tube technique. Maybe what is some different compared to the conventional tube technique? And the second question is that your technique is air-based technique. Currently, we use the mainly some water-based technique. What is some difference is that?
Very nice question, Dr. Kim. So the conventional tube, like EasyGo system, is also good. The difference between the EasyGo tube and this standard tube is that this is the mobile, no need to fix. And that mobility we can use, that we can, after once, we become more acquainted with all the cases like cervical lumbar. So we can decompress at every corner of the lumbar and cervical spine at the level of 4 corner, like we can decompress contralateral side, ipsilateral side, all the foramina because they're mobile. Second advantage is with the single incision, we can decompress at the 3 level, which also, of course, can be decompressed at that level. This is just a tube, more economical also. And you will say it's a air-based system, not a water-based system. So while you are learning, you are in a learning curve. The most important advantage, what I feel, the learning curve is relatively easy while you are starting the procedure. You should start with this kind of tube because, all spine surgeon, neurosurgeon are more familiar with the microscope and two-hand surgery with the 2 hand. With the water-based system, with the single hand, the learning curve is little bit tight and, more long. So relatively, this is the difference I feel.
Okay, thank you so much. Your great lecture, and we will move to the next lecture. And the next lecture will be from Jose Lame Guerra for posterior with the water irrigation system. Dr. Jose?
Thank you so much for I'm going to try to share my screen. Just a second.
You must just click on the share screen button on the below. Green button, share screen.
I'm just changing the configuration of my computer because I
now you are on.
Okay.
Yes, we can see. Yeah.
Okay, got it. Are you seeing my screen, the whole screen?
Yes.
Yes, so we can see whole screen.
Okay, perfect. Okay. Thank you so much. I'm Dr. Lamne, neurosurgeon from Colombia. Thank you so much to the World Federation of Neurosurgical Societies for the invitation to this webinar. I'm going to be talking about endoscopic spine surgery, the posterior approach with water irrigation system in the next 50 minutes. So let's start. So there are two kinds of approaches to the posterior region of the spine. The uniportal approach, which uses the working channel of the scope to guide the instrument to the spine, and the bipolar approach, which use one incision for the scope and a second incision for the instruments. Both approaches are good and resolve the most problem of the spine, but I prefer personally to use the uniportal for the reason that I have been working with this method for the last 10 years. Both systems use irrigation during the entire surgery. You can use a pump, or you can let the fluid fall by gravity through the bags. The working channel of the scopes are normally 4 millimeters, and when we use a pump, we should use a pressure of the pump below the diastolic pressure of the patient in order to avoid excessive pressure to the neural structures. If you have a bleeding, you can increase the pressure of irrigation and volume, but only for a short time. Regarding the irrigation, use normally saline irrigation or ringer. I prefer to use ringer because it's more similar to the CSF. We also, in endoscopic spine surgery, use radio frequency because it produces less heat to the neural structure. The instruments that we use are similar to the instrument that we use in open surgery: forceps, scissors, rongeurs, and many drills like hooded, diamond, and so on. There are many brands and drills in the market. They do almost the same. One of the advantages of endoscopic spine surgery are that you perform the same skin incision to all the patients. It doesn't matter how is the weight of the patient. At the beginning of the learning curve, it is more frequently to get a complication when you start to perform endoscopic spine surgery. The rate of complication in the first 100 cases reach approximately 18 until 20%, but after the case number 100, decrease until approximately 3%. There are in the literature some publications regarding the complication related to irrigation during endoscopic spine surgery. For example, by performing a neurotomy, there are some publications that describe the increase of the pressure through the irrigation with possible effects on neurological deficit. But I have to be honest, I have been performing almost 2,000 cases in the last 10 years, and I haven't seen my patient this kind of complications. The reason could be because of the endoscopic spine system that I use, and the fact that I control the pressure and the fluid frequently during the whole surgery. I had, of course, complications like bleeding, infections, opening of the dura, but until now, no one has been a serious complication during endoscopic spine surgery. So let's move to talking about the standard approaches. There are two access to the spine using an endoscope. The first one is the foraminal approach, and the second one is the interlaminar approach. Depending on the size of the foramen, location of the dissemination, you can select the most indicated approach. For example, the lateral, the posteroral, and extraforaminal for the foraminal approaches, and the interlaminar one. Then let me ask you the following question. Which cases are proper for endoscopic lumbar discectomy? The answer is all kinds of lumbar disc herniation could be performed with the endoscopic spine surgery. For L1 to S1, interspinal, foraminal, extraforaminal, they would be appropriate to be performed with endoscopic surgery. The approach will be selected depending on the location of the problem, the height of the hip. So you can select between transforaminal or interlaminar approach. The posterolateral approach is the most common use for the transforaminal approaches, and is most indicated when the pathology is interdiscal or when the pathology is located in the foramen. The extraforaminal approach is indicated when the pathology is in the spinal canal, a medial pathology, or mediolateral pathology located. Then let's talk about the surgical technique. Let's talk about the transforaminal approach. We start with a prone position. We try to define the entry point with the lateral X-ray. We look at the point between the facet joints and the spinal process. Then we switch the X-ray to the AP view, and we tilt the X-ray to see the parallel end plates. We mark the middle of the disc level that we want to operate. And in the cross point between the two lines, we perform a skin incision of approximately 7 millimeters. We insert a needle until we reach the midopedicle line. Also an X-ray lateral view to be sure that we reach the foramen. Then we remove the guide wire and we insert the dilator to the final position. We insert the working sleeve and that is the view that we have. We identify the anatomical structures. We prepare then the soft tissue using the probe of the radio frequency, and we cut the posterior ligament, the PLL, with a punch, and finally, we the structure depending on the location of the, and we remove and we decompress the nerve root. Then let's move to the surgical technique of the interlaminar approach. With the development of the interlaminar approach performed by Professor Sebastian Putten in Germany, the indication of the endoscopic spine surgery increased because these new access allow us to perform over-the-top decompression in lumbar and cervical spine region that was really limited by the transforaminal approach in the past. As I told you before, we use the interlaminar window to access to the spine through the flavum ligament. This will be the view by opening of the flavum ligament. You see the dural sac and the nerve root. For the surgery, the patient in the same prone position, we mark the window in the middle of the flavum ligament, a couple millimeters away from the midline in order to avoid any conflict with the spinal process. We perform the skin incision approximately 7 millimeters, and we have to be sure that we open also the fascia of the muscles. We insert the dilator until we feel the flavum ligament, and we switch the X-ray to the lateral view, and we insert the cannula of the endoscope. We insert the endoscope, and we start to remove the muscles and soft tissues. We identify the flavum ligament and prepare the soft tissue using the radio frequency probe, and we open the flavum ligament from the medial to the lateral aspect until we reach the medial border of the facet joint, and we have to push all the time and to perform lateral stretching of the ligament in order to see when we cut the ligament and avoid any injury of the neural structures. So we identify the neural structures and we identify the nerve root. We use the then to mobilize the nerve, and we use the working sleeve as a nerve retractor. You have to be careful when you rotate the sleeve because you can injure the nerve root. So after rotation, we identify the disc herniation. Okay. Finally, we open the PLL and we perform the resection of the disc as we perform normally in an open surgery. We are removing the fragments and we decompress the nerve root. So that would be a L5S1 surgery. But if we want to perform this herniation surgeries in higher levels, or when we want to let me put a mute here of the got it. Or when we want to make spinal stenosis, then we will use a drill in order to drill the facet joint and to make the over-the-top recompression. That is needed also. This is a short video. It's an example how you can perform this severe stenosis uses endoscopic spine surgery. It's possible to perform a decompression bilateral, as you see. Absolute decompression, over the top decompression. It's a surgery that takes approximately a couple hours, but you can perform really complicated multi-levels over the top spinal stenosis decompression with this kind of approaches without any problem. You can also perform cervical disc removal with only a skin incision of 5 millimeters. You can use always the instrument, a shorter and thinner instrument to remove this herniation on the cervical spine and decompress. Also, you can make a stenosis in the cervical region. Foramen stenosis is also possible to perform with this kind of approaches. I recommend always to start with easy cases, not only with the transforaminal approaches, but also for intraminal approaches. It doesn't matter if you are an experienced surgeon, you should respect the learning curve in endoscopic spine surgery in order to avoid complications. The learning curve will take time, but once you grow up with the technique, you will be able to perform the same surgeries that you do in an open way using an endoscope. Take your time to increase the level of difficulties of the surgery. Start with discectomy L5S1, continue with discectomy L4-5. Afterward, you can perform lateral recess decompression, over-the-top recompression, spinal stenosis, severe spinal stenosis decompression, and at the end, you will be able to perform cervical and combination with other techniques like cages, implants, and so on. We get in Colombia physicians of all Latin America countries. We have a lab with a integrated navigation system and phantoms and endoscopes to shorten the learning process in endoscopic spine surgery. If you will want to visit us, you are very welcome in Colombia. That was my speech. Thank you very much for your attention.
Okay, thank you so much, Dr. Jose. Still have no question. Maybe I have some questions that maybe how much today's topic is the some fluid irrigation system and endoscopic spine surgery. How much you control the fluid pressure in the lumbar, thorax, and cervical? That is the first question. And second question is that in the cervical area, there also can possibly anterior and posterior approach. What is your indication of posterior approach?
The indication for posterior approaches in spine surgery, in endoscopic spine surgery, are the same indications that you have when you perform an open surgery. The only difference is the way how you perform the surgery. You can do a laminectomy, you can do a foraminotomy, you can perform a discectomy, multi-levels using the endoscopic spine surgery. The only difference is the way of how do you perform that. So I didn't understand really good the first questions. Can you again ask me again the first question, because I was it was a delay.
Fluid pressure, maybe some decompression of the cervical and thoracic decompression, sometimes danger with the fluid pressure. How you control the lumbar, thorax, and cervical?
they're afraid with the neurological deficit. Are you talking about neuromonitoring or something like that?
No. Fluid pressure, irrigation
The
pressure.
fluid pressure, as I told
Yeah.
you before. So I use a system that control automatic the fluid pressure. But when I have this kind of system, I try to use the maximal pressure of the system below the diastolic pressure of the patient. For example, is the diastolic pressure
How much?
no more than 50.
50. In the
That is
lumbar or thorax cervical or?
I always use a endoscope with the oval form in the cannula. So in that case, the pressure that you put inside of the nerve system is not going to be varied by the pressure, because it is always a similar pressure of the between 15 and maximal 20 millimeters water. In that case, the problem is when you use a system and when you close the whole system and you put a pressure for a long time. That is a big problem. You can damage the neural structure. So I recommend always to use the system and to try to avoid the cap that many surgeons use in order to increase the pressure inside.
I have one question.
Yeah.
Harrison. Yeah, Dr. Jose, do you teach all your residents the endoscopic spine surgery, or do you prefer to start their learning after finishing normal residency? What is your behavior?
And this is a very good question. Thank you. I think we have to teach the both techniques, because I got the residence in the last learning year. This is normally in the 5th year, and they have been working with open surgery for 4 years. But I think if you have to perform endoscopic spine surgery, you have to master the open surgery. I think we have to master both kind of surgeries. But we start with open and then we switch to endoscopic spine.
You know what? At the time of my residency, the chiefs or the senior surgeons were doing microscopic surgery, and they were not allowing the residents to use microscope. Now, probably it is like the similar. They don't allow the current seniors do not allow the residents to use endoscopes. In general saying, and we can discuss it later after finishing all the talks. And I must tell that Dr. Benedict is with us. He's the other moderator. And thank you for very nice presentation.
Thank you so much.
We finally met Dr. Benedict. Benedict?
Yes, hello. I'm sorry for the delay, but on my time sheet it was scheduled 4:15 German time and not 3:15. I'm very sorry.
Okay, can you start to moderator?
Yes. So I guess you are the next talker, correct?
Yep.
Yes.
And I'm pleased to see your talk about endoscopic fusion techniques of the spine.
Okay.
And later on, then I will give an overview about endoscopic surgery, and then I hope that in the end we have a good interactive discussion about where we stand with all what we heard so far and what we can do in the future. So please go ahead.
Can you see my slide?
Yes, very well.
Okay. Thank you so much, Dr. Benedict and Professor Mehmet Jirali. This session is my session is that the endoscopic fusion, and this session is the endoscopic spine surgery. Is it the new standard? I'm also performing the uniportal full endoscopic spine surgery more than 20 years, and today I'm talking about that the endoscopic lumbar fusion will be the next generation. Okay, this is my curriculum by 10 disclosure. Yes, currently the people's mean life increased so much because of that some increasing the lumbar stenosis and that need some decompression and fusion increased so much. Because of that, there also will be the medical problem in the future. Maybe so many patients that they need some recover their normal life and normal activity. And fortunately, endoscopic spine surgery developed so much, and we already well known that they may be divided in two generation of endoscopic discectomy, and first generation of transforaminal, second generation of intraminal. And now we going on the third and fourth generation of the endoscopic decompression and endoscopic fusion generation. And now also we so many instruments and equipment also developed sufficiently to support this endoscopic decompression and fusion. This is my data of my career during last 1 year. Here we can see the very important data is that with performing the well decompression, well discectomy, and well decompression, not only lumbar but also thorax and cervical, and also for the lumbar interval fusion, that we can perform the near all patients can possible endoscopically. This 1,700 cases of during last 1 year, we only performing 4 cases of open surgery, 2 here, HDF with the cervical myelopathy cases only. Another all patients can possibly managed by the endoscopically for decompression, discectomy, fusion, cervical myelopathy, and thoracic myelopathy, and foraminal stents, all things. And now we checking the endoscopic uniportal endoscopic lumbar interval fusion. But here we can see the 3 endoscopic approach currently introduced that firstly, a transcambient approach introducing, but nowadays they're introducing the intraminal approach and a paraspinal approach together. And I mainly use this paraspinal approach. There have 10 surgical steps of the endoscopic lumbar interval fusion, and also endoscopic lumbar interval fusion mainly similar to the transforaminal open lumbar interval fusion. Because of that, the technique is near similar to the open transforaminal lumbar interval fusion. Here we summarize that the 10 surgical steps of the endoscopic posterolateral transforaminal lumbar interval fusion. There have the here you can see the step 2 finding the Kim's point in the endoscopic lumbar interval fusion. First important step will be the resection of IAP and resection of SAP, then the opening the transforaminal space. Because of that, how much we can decreasing the operation time to resect the SAP and IAP will be very important. Before we use the conventional medial to lateral resection technique for IAP resection, but there is sometimes a long time operation time. But if we use the Kim's point, this Kim's point already published in the paper of the brain science by me, and we using this technique of the IAP resection. SAP resection also similar resection procedures. Then we can decrease in the operation time so sufficiently. Now you can see the next step of the IAP resection. I already mentioned that first researching the Kim's point and resect from medial lateral to medial IAP pars portion, then remove the resected IAP, and then SAP resection also similar procedures from lateral to medial. And this line also find from above the pedicle above line, then you can resect SAP sufficiently. After then, we can expose the transforaminal area. Next step of the two step will be very important tips of the endoscopic lumen interval fusion. You can see here there's some chronic adhesive disc in the opening. After opening the transforaminal area, we can find the disc area. Then so many patient cases we can see the so collapsed disc space. Then make some focal segmental collapse and sometimes discoid collapse. If we sufficient restoration, that point will be the success of the endoscopic lumen interval fusion and also success of the correction of the spinal alignment. And also, next step is some after chronic adhesive disc drilling. Then next step is the end plate denudation. This is also a very important process of the endoscopic lumen interval fusion. You can see here the end plate denudation without damaging the end plate. This is very important to achieve the sufficient fusion rate and sufficient decreasing the substance rate. There is a main goal of the endoscopic lumen interval fusion, like open lumen interval fusion. Because of that, this process also very, very important process. And the next step will be the some before time some delivering of the KG to the target point is a main worry of the endoscopic spine lumen interval surgery. But fortunately, currently, I introducing this Harrison cage glide. You can see here, Harrison cage glider for protecting the traversing nerve root here, exiting nerve root together. Then first insert like this way of the vertebral body, and you can see here the disc space, and then rotate insert into disc space. Then you can see here again pushy and insert the follow the obturator and then insert and rotate. Then you can insert the cage to the target point like this method. Then next step will be to insert the cage to the target point like this way, like this, and the final screw. This postoperative skin image of the endoscopic lumen interval fusion. And also currently many paper published for the scientific based basis of the endoscopic lumen interval fusion. You can see here the paper published by me. I already mentioned that the Harrison cage glider maybe protects the traversing and kicking nerve root. Because of that, we can safely deliver the cage to the target point in spite of the very small working space. And also this using the Kim's point, we also can decreasing the operation time. Maybe usually my operation time of the skin to skin for one level lumen interval fusion usually need less than 1 hour or 2 hours, usually 1 hour 30 minutes. And also this paper published by me in the Global Spine Journal talking that the fusion rate and more rapid and more sufficient fusion rate can take in the endoscopic lumbar interval fusion. And also substance rate also more decreasing compared to the open transforaminal lumbar interval fusion. And also I already mentioned that maybe in the endoscopic lumbar interval fusion, very distinctive techniques of the these two techniques, chronic adhesive disc drilling and end-plate dentation, is a completely different and distinctive technique compared to the open transforaminal lumbar interval fusion. That will be main advantage of the endoscopic lumbar interval fusion. And also using this chronic adhesive disc drilling, I already mentioned that in the cases of chronic focal segmental collapse so severe and disc collapse so severe, spondylolisthesis so severe, also in these cases also can take a sufficient restoration of focal segmental correction, sufficient restoration of disc height, sufficient restoration of the spondylolisthesis can possible. This also already published in the paper by me. This is very important to performing the endoscopic lumbar interval fusion for the degenerative cases for malalignment spinal alignment cases of degenerative scoliosis, sometimes degenerative kyphosis cases. For example, these cases using this technique, you can see here cases so severe collapse in the L5S on disc space. In these cases, before time, this is not in the posterior approach. Because of that, many doctors try the anterior approach to restore this case severe collapse and spondylolisthesis restoration sufficiently. But because of that, some operation risk also increase some more compared to the posterior approach. Because of that, if we can possible by the endoscopically like this way and like this, then the patient, we can more safely and more sufficiently restoration of the patient's result, and then make then meaning that the more good clinical result to the we can give a more good clinical result to the patient. Also, similar cases of like this also in the L5S spondylolisthesis cases need some large some sufficient restoration, and larger angle maybe need some sufficient spinal alignment correction. But in the previous concept, open surgery, this is not in the posterior approach. Because of that, it needs some anterior approach. But nowadays, using the endoscopic lumbar interval fusion, we can restore sufficient and we can give the sufficient angle, and sufficient restoration is all possible by the chronic adhesive disc drilling technique. For example, like this cases of some very difficult cases of the spondylolisthesis L5 and L5S retrolisthesis so severe case because of that, in these cases, the posterior approach will be not in the open approach. Because of that, maybe need some another additional technique. But if we can possibly by the chronic adhesive disc drilling to apply these cases, also we can take like this result. You can see the sufficient restoration of the L5 and L5S together, and also spinal alignment also corrected very successfully. And I already mentioned that using this chronic adhesive disc drilling and end-plate dentation and the 3D printed KG, then we can nowadays we can take a more sufficient fusion compared to the open transforaminal lumbar interval fusion. Then meaning that the more good we will give a more good clinical result to the patient. You can see this image take on only 2 years. Because of that, using these several techniques of the endoscopic lumbar interval fusion, nowadays we can apply the for degenerative scoliosis cases, and I am also already published this tech cases in a paper, World Neurosurgery. You can see here the degenerative scoliosis corrected sufficiently after operation. Chronic adhesive disc drilling technique. For example, like these cases, for all the patients may be degenerative scoliosis, they need some correction of several segments. And this also loss of spinal alignment together. But if we can possible using the chronic adhesive disc drilling, endoscopic lumbar interval fusion can take a sufficient restoration of spinal scoliosis and spinal kyphosis together. And also this case is also pelvic surgery cases also looks like very difficult cases and degenerative scoliosis. But using the endoscopic lumbar interval, you can see here and here, then you can see the sufficient correction is possible. And also the patient can take a sufficient spinal alignment correction, and then meaning that the patient real excellent clinical result to the patient, and then meaning that the patient can return to normal life more sufficiently. And also using this technique, currently we can apply to the degenerative kyphosis cases. You can see here degenerative kyphosis for and try the 3-level lumbar interval fusion by the endoscopic lumbar interval fusion. Then postoperatively, you can see some correction, but 6 months and 1 year later, the patient's spinal alignment corrected near completely. And also, like because of this advantage of the endoscopic lumbar interval fusion, nowadays we can more successfully apply to like this degenerative scoliosis and kyphosis cases like this way. And also nowadays we also tried a more new trial for new endoscopic spinal surgery. For example, fortunately, using this endoscopic spinal surgery can decrease the blood loss. Because of that, during last 1 year of my clinic, of 190 cases of endoscopic lumbar interval fusion, we have no intraoperative transfusion, only postoperative and preoperative transfusion only. This is very important for geriatric generation, because of some transfusion also maybe sometimes maybe some danger. You can see this patient also have no transfusion during the operation. After operation, only 1 pint transfusion only. And because of that, nowadays we can possible to, in spite of the endoscopic lumbar interval fusion, no open surgery, no general anesthesia, no suture, no dressing, no transfusion is possible. And also we try to decreasing the infection rate in the endoscopic spinal surgery. And also you can see here this 85-year-old male patient for then the fusion surgery. And after operation, you can see the sufficient success clinical radiological result. And also, currently we try to the large angled cage in the posterior approach. Like this large angled cage in the previous concept, it only can insert in the anterior approach is possible. But nowadays, using the chronic adhesive disc drilling can take a sufficient disc distraction is possible. Because of that, now that we can insert in spite of the larger angled cage insertion is possible. For example, like these cases, this patient received the L4-5 interspinal device before, but now L5 severe collapse. Because of that, this patient needs some correction of the L5S1 angle correction that maybe needed. This patient needed. Using the chronic adhesive disc drilling, we can take like this excellent clinical result with a large angled cage. That meaning the spinal alignment also corrected more sufficiently, meaning that the patient can possibly more sufficiently return to their normal life. For example, like this case is also received the 2-level fusion decompression before, after then the patient take a failed back surgery cases. You can see L3 phosphorylates, L4-5 Metastases. Because of that, if we hope to successful surgical result to this patient, we need some large angled cage for L3, for L4-5. Because of that, maybe before time, this case need try to the lateral approach or anterior approach. But if we try to insert it using the chronic adhesive disc drilling, we can insert like this larger angled cage insertion is possible. Then the patient can possible sufficient spinal alignment correction is possible. And the currently bipolar surgery also can 3D large angle cage insertion also can possible. And also now I'm also thinking that in spite of the excellent clinical endoscopic spine surgery can take us excellent clinical results, there more need sufficient rehabilitation after operation, and I'm trying to skywalking system for so many geriatric patients and so many fusion cases patients. And then using this process, in the cases of long level fusion cases, we can see because of that endoscopic spine surgery preserving the all structures of the skin and all structures because of that. You can see here that in spite of long level fusion, the patient have a spontaneous restoration effect. I'm thinking this concept maybe keep the tensegrity, make some like this spontaneous restoration effect in the spinal segment. Fortunately, like this development of the endoscopic spine surgery, you can see this patient maybe received a long level fusion for degenerative kyphosis, and you can see still the failed back, and the patient come to my clinic with a near complete pelagic state. You can and then you can see this so severe cord damage here, but using endoscopic spine, endoscopic lumbar fusion with the chronic adhesive disc drilling, and with some skywalking system of rehabilitation system, you can see after operation, we removed all this area, only fixation only 2 years, short segment fixation. In spite of them, post-operative and post-operative whole spine looks like not completely restored, but after then rehabilitation doing, and then 1 week later, 2 weeks later, 3 weeks later, and the patient also have a more good recovery. She's working, and then 4 weeks later, the patient fortunately can pass over by himself only. In conclusion, I believe that in the future, the spinal surgery also will be developed so much, and we will to the target of the robotic surgery and next generation of spine surgery. But I believe that all this process may be based on the endoscopic spine surgery, and also success of the endoscopic lumbar fusion is the key to success of the whole degenerative spine by the endoscopic spine surgery. Thank you for your kind attention.
Thank you. Very nice presentation.
Yep. Thank you so much.
Yeah. Any questions from the audience in the chat? In the chat, I do not see a question. I have one question to you regarding the cage placement in the revision cases. Do you remove the hardware first to get a better access when the segment is collapsed and the rod might be in the way?
Yes, in the revision cases, I always remove the implant first and then operation starting like first operation. It means that they have to remove all implant and then operation start again. Always.
Very good. There was another question from Dr. Zatara.
Yeah. So, Dr. Kim, it is fantastic presentation. You have shown very interesting slide that you have shown that for spinal neuro rehabilitation, use the Skywalk system. So,
Yeah.
so how it will benefit the patient? What is the idea behind that?
Yeah, actually, the Skywalk system is made by me, and it is not used in another clinic, and because of that, it made by me. But there is a very advantage to the some nerve damage patient of the weakness. The rehabilitation recovery is very, very rapid. For you see the cases of my cases, the patient near complete plegic state, but now only 4 weeks later, the patient can possibly by walking by herself.
Interesting.
I have one question.
Yep.
Yeah. Actually, Harrison, do you place the screws first to facilitate distraction of the disk space, or
No,
you make first interbody fusion?
yes. I believe that some natural restoration of the spinal alignment is first. Because of that, I'm not insert the screw first. I'm insert cage and bone chip first. Then make try to the spontaneous restoration of the spinal alignment by the patient self.
Okay.
Natural correction, I like it.
I have another question. The sheath you introduce, you said that first you introduce it and protect the exiting and transversing nerve root. Do you see the tips of that bevel sheath endoscopically, or do you place it under fluoro?
Fortunately, we performing the dissectomy first because of that we can insert the object to their disc space. Then
but you rotate it, right? You rotate it. You have the tips are first.
My glider follow the operator that inserted already inserted into the disc space. That means that there is a safe area, and then insert firstly. Yeah.
Okay. And what's the diameter? What's the diameter of that tube?
Tube maybe 12, maybe. But you can push it and decreasing some more.
Yeah, but I mean that.
And also kg, I usually use the kg, maybe kg size usually 12 or 13 millimeter, and sometimes I use some 15 millimeter kg insertion is possible.
So the diameter, inner diameter of that tube with the tips is also like 15 millimeters probably, that you can fit.
Yeah, tube size maybe increasing and decreasing is possible.
Yeah.
Yeah.
Okay, very good, very nice. Do you think that when you see the disc space and when you see the end plates and prepare them, that this is the success for the high fusion, or is it mainly related to the cage?
Please question again.
Do you think that because you see the end plates endoscopically and you can prepare the end plates endoscopically and flush everything out with the irrigation, that this is the key for the high fusion rate, or is it more related to the cage design itself?
Yeah, it may be high fusion rate, maybe some related to not only end plate generation, but there is some very big advantage. But I already mentioned that the 3D printed cage also very important. Fortunately, using this process, maybe substance rate very, very low. screw fail, cage fail is very low.
Okay.
I
Good.
have a last question. Could you do you find any difference between the placement of a cage between 3445 and L5S1? Because there are some troubles when you try to do to drill the ascending facet in the L5S1. It comes the transfer to nerve root, and it's really difficult to place a cage with this form. So I always use like I remove the flavum ligament and I try to use the same way that I use when I do bleach surgery. Do you do the same in endoscopic spine surgery, or is quite different?
Yeah. Currently, I believe that the indirect decompression, I already published the paper in the Neurospine maybe last year. Currently, decompression case, central decompression is so rare. Well, mostly only insert the cage only in the transforaminal space. And also, your question is that like the maybe I always use the 2 kg in the L5 and L5S above level one kg because of that the foraminal space is above is so narrow and below L5 and L5S is so wide the foraminal space because of it we can insert the 2 kg insertion is sufficiently inserted is possible. But and also using this technique, we can decrease the substance rate more sufficiently.
Okay, thank you so much.
Very good. Okay, I think we continue. I try to share my screen. I hope. Where can I share my screen?
Share screen button at the bottom of the
I only
screen.
have chat registration.
No, share screen.
Yeah. It's not there, unfortunately. Hold on. Yes.
Yapmak üzere.
Okay, now here we go. That's good. Can you see it?
Yes, yes.
Okay. Yes, we can see.
Yes, very good. Okay, so I would like to talk about endoscopic spine surgery and is it the standard for the future? I'm honest to give that short presentation, and it's 10 years ago, and I had to write a paper for the World Spinal Column Society with the same topic. And today in my talk, the agenda is that I want to shortly talk about an overview about state-of-the-art endoscopic spine surgery, because there are different techniques. What an endoscopic spine surgeon should have kind of criteria for the surgery. That the pain generator is a concept that if your philosophy is endoscopic spine surgery, you should involve. And what we should think about for the future, as has been already mentioned in the previous talks, how to treat patients, especially with the population that's becoming older. You see here, this is the paper I wrote 10 years ago. And I have to say that over the last 10 years, if you see what has happened in the literature and in the industry, endoscopic is pushed and pushed and pushed further more. And but if you look at least in Western Europe, it might be a bit different from Asia. The numbers of procedures overall, they are rising, but the industries, if you talk to the companies, sometimes they are struggling to gain a bigger portion of the market. So let's start with the state-of-the-art endoscopic techniques. We know that with endoscopic techniques, and this has been well documented in the literature, we can not only treat lumbar disc herniation or spinal stenosis, we can also treat pathologies in the cervical, thoracic, and lumbar spine. And even now with the fusion techniques, we can treat instabilities or even deformity. If we talk about endoscopic techniques, endoscopy actually is a tool of visualization, and you have different techniques where you can visualize the surgical field using an endoscope. The oldest technique among those, which its origin dates back in the 1970s, is the uniportal single instrumented technique with continuous irrigation, and the Cambin triangle that is well known to everyone dates back to a surgeon that actually wanted to use the endoscope to make sure when he performs the nucleotomy percutaneously that the nerve root is not in the way. The way we use now the endoscope was not the idea in the past back then. Then a second technique we have is a tube-based system. We heard to talk about this earlier, and in 1996, Foley and Smith first described the use of a 50 millimeter outer diameter tube-based system to remove lateral disc herniations, and then later on with the metric system, the indication of surgery was further expand. The tubes became wider and fusion procedures were performed. The third technique is also old. It was first described in 1984, but nowadays it's popularized widely on the market. It's the unilateral biportal endoscopic surgery, where you can either use a posterolateral, interlaminar, or translaminar approach for your surgery. Here you can see images from Rütten from Herne, who has performed extensive trials and publications regarding disc herniation of the lumbar and of the cervical spine using different approaches, as you can see here, transforaminal, posterolateral, and interlaminar. This is an image of the uniportal bimanual technique with no continuous irrigation. The irrigation can be performed by an assistant, and this is the Storz system. Easy go, but there are other systems on the market, or were on the market, from Medtronic, the metric system first, that allowed to perform a wide variety of surgeries for different pathologies. Even though also you can perform fusion procedures using this technique with an approach that is probably pretty similar to what we saw from Dr. Harrison Kim previously. And then lastly, the biportal arthroscopic system that has been first described by Antononi in 1984. And now it got back on the market, or it's popularized, and a lot of publications came lately out that reported that this technique is as safe as the microsurgical technique too. If we look at these different techniques, and we look at the literature, because we want to treat patients, and we do not want to treat patients only for a week or two. We want to try to get good clinical outcome in the long term, 2 years, 5 years, or maybe 10 years. And there is a publication that it's old, that compared transforaminal, microendoscopic, and microsurgical techniques to each other. Here you can see the transforaminal approach. You can see here the microendoscopic approach and the microsurgical approach for disc herniations. And over a 2-year span, all these techniques that have been used for the treatment of disc herniations overall had the same clinical outcome. There was no significant differences, or the significant differences in reoperation rates with either one to the other. It was stated that if you have a high canal compromise, or the disc herniation is sequestrated like widely cranially or caudally, you have to be very cautious using the percutaneous endoscopic technique, because there might be the chance that you could not remove everything or you could get an early reoperation. So again, patient selection and also surgical skills are key for each of those techniques. The clinical outcome after 5 years drops down a bit from 80 something to 78% in the percutaneous endoscopic group. And here you can see that the results were still excellent, but again, a few of those patients who reported early a very good result maintained this very good result later on. If patients had not an excellent outcome in the beginning, they might have not a risk, but they were associated with higher rates of reoperations or surgical procedures as at other levels. Also, this study from Kai Lewandowski compared the inside out and the outside in technique. And with the inside out technique, at least in their group, they had less reoperations compared to the outside in technique, where they might sacrifice a bit too much of the joint. At least that's what the data in their group showed us. If we go to the microendoscopic surgery and look at the 5-year clinical outcome rates for lumbar canal stenosis and disc herniations, here you can see a study that we performed at the University Hospital in Homburg-Saar, Germany, where I previously worked. We had a couple of hundred patients with 2 different generations of microendoscopic systems. We compared the systems to each other, and at least for the lumbar spine, after 5 years, patients reported very good clinical outcome. They were very satisfied, but even though reoperation after 5 years were still there, 20% in the first generation, 10% in the second generation, especially a difference we had for the cervical spine, where we probably had a very high learning curve, first of all, and second of all, in the end, the indication for our endoscopic posterior cervical foraminus were very, very strict. Very, very strict. I think especially in the cervical spine, if you do posterior approach, you have to be very strict to get a very good clinical outcome, because the anterior cervical discectomy still is, and also in the long term, a very successful procedure. Then if you go back to the literature and look in the overall and do a meta-analysis of a couple of thousands patients that have been operated either with a microsurgical decompression for lumbar stenosis or disc herniation, and try to compare, is there any difference to endoscopic procedures, unilateral, uniportal with continuous irrigation? You see that if you have like a couple of thousand patients and compare them to each other, that the data, the clinical outcome data is the same, but it should be not underestimated that the surgeon, and we heard this earlier too, needs a certain skill level to achieve a good result. So overall, if we look at the available clinical outcome data that we have so far, we know that endoscopic techniques offer the same clinical outcome as traditional microsurgical decompression for degenerative disorder in the short term, and that also has been published like a lot. Endoscopic techniques are associated with less blood loss, shorter hospital stay, less need for pain medication, less wound healing problems. I think this is the hardest selling point, let me phrase it this way, and early return to work. However, if we nowadays, where other techniques have been refined, also look at these data that has been published and compare them to minimally invasive techniques that do not use an endoscope, it's very hard to find a statistical significant difference that really matters to the patient. Let me phrase it this way. If you have a blood loss of 50 or if you have a blood loss of 10, a healthy patient will not see a clinical or not will report a clinical difference. Also, what do we then, and I hope we can later on discuss, about this. We have to look in the long term of, are the results, do they have a better durability, reliability? And can we get lower revision rates for surgery using those new techniques, first of all? And second of all, it has been reported often that the healthcare costs are less using endoscopic techniques, but this might not translate or be translated to all the countries, because the healthcare systems are different, and endoscopic techniques that are used often use single use instruments, and they might not be reimbursed, and therefore the healthcare costs might not be really lower. So the criteria for surgery, when you have been trained in microsurgical techniques and at an academic center, you very much rely on imaging data. And if the image does not show a significant nerve root compression or instability or deformity, but the patient has problems, you might not go for the surgery, but for other treatments. If you are used to perform endoscopic procedures, you are very well trained placing needles and doing also injections under fluoroscopy. And because of this technique, you might have seen structures that are not visible on the MRI. And again, there, Kai-Uwe Lewandowski from the United States performed a study where he assessed the preoperative MRI report and then looked back, what did he see actually in the procedure, because the MRI report stated that there is no significant decompression. The patient proved from a previous nerve root injection. And regarding to his paper that has been published, the false negative MRI reports are about 35%, which means that about 35% of pathologies that are visible with an endoscope are not seen on the MRI before surgery. If you go back and look at it, how is epidural, not an epidural, a nerve root block in comparison to the MRI, you can see that the false negative rate is significantly lower, which means that if the patient benefits from a selective nerve root block, and even though in the MRI there is nothing visible, either do the MRI again, or you might do an inspection with the surgery. So what kind of pain generators do we have? There is not only a disc herniation or a synovial cyst or hypertrophic ligamentum flavum. You can also have inflamed nerves, as you can see here, or tethered nerves that are attached and not mobile, even though the patient did not have a previous surgery. Also, you can have hypervascular scars that, depending on the vascularization, may also cause pain, even though it's not seen on the MRI. And again, here in this literature overview, you can see that there are a lot of different pathologies that you might miss on a preoperative MRI, but can cause problems to the patient. If we look at the population in the world overall, we see that up to 2040, 2050, probably the world will grow, but then it will, because of lower fertility rates, the population will shrink. But up to that point, the patients that are born will become older and older and older due to the life expectancy, which is, if you're born now in the world, 75 for male and 80 for female. But if you're born then in 2100, it's 84 and 86, which means that the patients that have degenerative disorders and problems with the spine will increase overall in the world. And low back pain is now the cause for death and disability, now already in 13% of the world population. regarding to the disease burden report, and this will increase. So for the future, we need protocols and we need good data where we can stat which kind of patient can profit from a surgery, first of all, and what can be then later on expect. If we now look at how do patients profit from fusion procedures, from endoscopic procedures, and from traditional laminectomies, we see that they all perform pretty good, but we see if the indication is selected properly, the patients with the full endoscopic transfemoral decompression, for example, they have the longest survival rate, which means that they do need another surgery. They often need another surgery as longer the follow-up goes, but the curve, as you can see here, does not go down as deep as compared to the open laminectomy group. But this has to be assessed in the future further. So from my perspective, for the future, what we should discuss or focus on, first of all, the surgery has to be cost effective, which means that it has to be reimbursed, or we need studies that can be provided overall in the world to healthcare companies to reimburse those procedures where we can properly document that they, over a long-term follow-up, offer hard and better clinical outcome compared to other techniques with regard to the cost of the surgery. We have to evaluate which patient profits from the surgery and which not, because lately, at least in the United States, the health insurance companies came up with the term valuable surgery. And because the number of transfemoral endoscopic procedures has risen, also the number of patients that are going to the emergency rooms or to other hospitals has risen too after the procedure. And this is not the idea for the health insurance. And then we have to look as surgeons, how can we educate younger residents or younger surgeons that what's really achievable and not. Because, and lately we wrote a manuscript about this, social media and the industries are pushing surgeons to one side, and we do not want to become in the situation where every thing looks like a nail because we have a hammer in our hand. And I'm pointing out these little sentences for the discussion that maybe is coming up now. And also, I would like to invite everyone to the 40th Jubilee ISMIS course, which will be held in Zurich at my institution on the 3rd and 4th of October in 2025. Thank you very much. Any questions?
I have something to say about it, about the cost. So I think the cost issue that we are currently facing with the endoscopic spine surgery is the same as with what we had 20 or 30 years ago with the laparoscopic gallbladder surgery. It's just a matter of time for the cost to gradually decrease. I think it's in 20 years, it's not going to be a problem to perform endoscopic spine surgery, and the prices are going down.
I'm totally with you that the prices are going down, but if you look how much they have to go down, you have to talk then to the industry how much, because if you use a 40 millimeter tube, for example, and you have a burr that costs 80, and you have a microscope sitting in your OR setup anyhow, the whole cost of the surgery is 80 euros, and the durability of endoscopes, even though the industry claims it's 200 sterilizations, it's significantly less in my personal experience. Depending on the sterilization type, it's maybe 40 or 50. And if you add all these costs up, the cautery, the drill, etc., and then look what really is the benefit after 1 week, after 1 month, after 1 year, and this is what the insurance companies are looking at, then you need good data. And if the industry pushes those techniques and there are more and more patients going to the emergency room, like in the US, because they have a problem after endoscopic procedure, because they are operated by untrained or unskilled surgeons, the industry will look at it. In Germany, I can tell you, a lot of the hospitals, this is not in the news, if you have the wrong insurance, you will not get this surgery because of the costs. It's just that simple. If you look at the literature, what they do, if you have a tube-based procedure, microsurgical procedure, they have high success rates. That's what you have to compare this to. And you can perform outpatient procedures. This was my last slide. Not using an endoscope. That's been done in the US all the time.
But there are many physicians, for example, in the USA, that by any discrimination, they perform all with fusion. If you compare the endoscopic spine surgery with that kind of treatment, we offer a cheaper version of treatment than the older ones. It's going to be. I think one of the role of the World Federation of Neurosurgical Societies is going to be to standardize this procedure in order to have a clear future in the decision making of so many problems. I think that is our role in the future.
Yeah, and that's why I just brought this up, that we need a good protocol, who will profit, who will not, that we don't have this problem.
Cost effectiveness is a very important issue, especially in the low and middle income countries. I must mention that the drill bits used for fusion for this endoscopic surgery or for the compression, they are very expensive. They are probably 1,500 euro, one tip only.
Absolutely.
Yeah, and the basic instrument set is about $80,000 or $100,000. It depends, because you need a RF generator, you need special motors for drills, special suction device, special tubes, everything.
They are not. They have no compatibility to other systems on the market.
Exactly.
And then if you have those and you use them for treating a disc herniation or stenosis, and you have a tube-based system, and you have only like 1/10, and in the end, after a year, they are all the same, and the complication rates are all the same, and you can perform outpatient surgery the same, then you have it's difficult to find a good argument why the insurance should pay this. And that's the discussion we have, at least here. I don't know how this is in Asia or in other countries, but that's the discussion we have here.
Sorry.
This is why the biportal surgery is growing up really fast, because they use normal instruments. Yeah,
absolutely. That's exactly, and it was invented in '84. It's not new. It's certainly not new. And if you look at the surgical technique that biportal surgery performs, this is no different from a tube-based technique or maybe from a microsurgical technique, because the instruments are the same and there is like water all over in the soft tissue.
Jose, you have shown very nicely that during the learning curve that you need to make 100 surgeries or something like that. However, during the first 100 surgeries, your complication rate is higher. Is it true?
Yeah, not only mine. So the complication of everyone who try to
in general for everyone. Yes. Not yours. Yeah, I didn't mean this. But actually, I know some good friends who have started endoscopic surgery and has left it because of a few patients had some nerve root injury.
Right. The problem is
intractable pain
because
of the nerve root injury.
Yeah, the learning curve is a long way. So the problem is that we are growing up and there are so many surgeons that they think they have enough experience making all under microscope the surgeries, and they will be able to perform the same surgery in a good way, and then that's the problem. They do mistakes at the beginning.
I think the problem starts with reading the MRI correctly.
Right.
I think there the problem starts, and indication. I think if you can read the MRI correctly and you have a good preoperative planning and you know the anatomy in the X-ray, if you use then the X-ray, you know, okay, when are the end plates parallel really, etc., then it's safe to do. But if you don't use to even read the MRI correctly, you can become in deep trouble.
Absolutely.
And again, especially for the good indications, foraminal and extraforaminal, and this has been published, it's a Turkey from paper in World Neurosurgery, for extraforaminal disc herniation, and this was an experienced group, I guess, because they had 100 patients in each group, extraforaminal disc herniation lumbar, they had 14% neurological deficit. 14, and so they must be way above their learning curve because they have 100 in the group. So if they do 100 extraforaminal, they do probably 500 procedures because extraforaminal is not that often.
You're right.
When the younger generation, started their careers, as Dr. Zileli was saying, first 3 or 4 years while they are on the learning phase, they even, hardly to get this kind of minimal invasive spine surgery, including the endoscopic spine surgery. When they directly brought up in the highlight into the private market or in the hospital, in the practice, they have a pressure because this option of endoscopic spine surgery to stay in the market is very, very lucrative options. So people were asking about, okay, I want to do endoscopic spine surgery. But in fact, they haven't even tried a minimal invasive matrix tube surgery. So one of the studies says that first 40 cases, you have a lot of neurological deficits. So ideally, we believe that we should start with the some kind of tube system. Then you understand the 3-dimensional anatomy. So wider to narrow corridor. If somebody will start with a directly water-based narrow system in their first 20 cases, definitely there will be some more and more neurological deficits. So I believe that the learning curve should be outer to inner and wider to narrow system rather than water-based system or waterless system. I think that is more important.
Yeah, that's true. I mean, if you look at the approach, I mean, for me, I can tell this full monoportal full endoscopic procedure, this is transforaminal for me. I don't see any benefit doing an interlaminar approach with this because in the old patients we see here, they have no musculature, they only have fat. This does not spare anything. If you use a 40mm tube or a 9mm full endoscopic tube, there is absolutely no significant difference. For me, this is transforaminal. But I agree. I mean, if you're used to work in a narrow corridor and then go back to another corridor, this might help. But for me, understanding the anatomy and understanding the MRI and understanding where you're at, how this tissue looks like on an endoscopic screen, that's for me the key.
I have one question for you, Dr. Benedict. I find your presentation very interesting. If we are talking about the future perspective of spine surgery, this is all panelists. Are we going, maybe after 30, 40 years, are we going towards motion preservation surgery? I'm talking about all the spine surgery. Or are we going towards the material, which is bioresorbable or biocompatible, which give you the natural bone and all the instrument will goes off? What do you feel? So means what happened after?
I feel that, I mean, what we see in the literature, that's my personal perspective, there is nothing new. Nowhere. There is nothing new. And you can argue from one to the other side. And I think every surgeon should select the surgery what he feels is the best for a surgeon and he performs best, because as long as I'm doing this, I'm convinced that you should see your patients a long time to really understand, have you done this correctly or not? Are we going to motion preserving or fusion? I don't see that, because motion preserving, they did this 20 years ago. And actually the Dynasys system, and we have a couple of hundred patients here with long outcome, like 10 years plus. This is from the idea, not a bad system. Problem is that the infection rates were so high due to the plastic. But can they beat the fusion procedures we do right now? Maybe in a few good selective cases, but not in all. I mean, you have to select the proper surgery for the correct patient. I personally think for the future, that's my last word, I think that we might understand using genetics who will profit from surgery, yes or no. And then someone will tell us, is this patient a candidate for surgery, like in the long-term future? Then I'm dead already.
Another
Because,
thing,
because, I mean, look, we see so many MRIs with stenosis and disc herniation in patients that are completely asymptomatic. Why are some asymptomatic and why others are not? And when we understand this, then we go a big step. But for microsurgery to tube-based to full endoscopic, this is marginable. This is so minimal to really assess a benefit. And the industry, they use it as selling, but I'm too old to that they convinced me.
Yeah. Okay, good. I think although the speakers here are very experienced endoscopic surgeons, and their results must be perfect. Like we have seen actually, Hyung-Sung Kim's fusion, even doing from a small tube, a fusion surgery. But in general saying, we cannot say still that it is a standard of care, the endoscopic spine surgery. Am I right?
You're right. I think it can be the standard of care for a very selective patients and diseases, but not in general, because when I hear this, it's a disc herniation. Not every disc herniation is just the same. It's just that.
Right. Yeah,
And
I completely agree, yes.
you can use the drill then and can operate on the disc herniation transfemoral like for 2 hours, or the other one is doing it in 20 minutes, and then we see what's the outcome.
Harrison, would you like to say something?
Yeah,
I think
yeah, in Korea, maybe still, I agree to Professor Mehmet really. Still some ongoing state, but currently, like some Benedict, we believe that some endoscope discectomy already is standard, but decompression also many doctors perform so much, and I thinking maybe standard becomes standard, not so far. But another so many techniques of the fusion and cervical thoracic decompression is still not standard. Maybe need some more development, and some still maybe need some that point some more development, some point of techniques in endoscope spine surgery.
I think the future will answer that question. So we will see what happens. I imagine a future with a 3-portal endoscopic surgery for tumors surgery in the spinal region. I imagine that that's what I think, what I see in the future. Less fusion, more decompression, more. That's what I see. I don't know.
I'm with you. I think less fusion, more decompression, because the old patients, 80 something, I always have a bad feeling when I have to fuse them.
Right.
Be honest.
And we are preparing our generation of people that want that is going to be more moving in the way to make exercise and to do. I think that we are going to decrease that kind of population that they are just with a muscle weakness. I think it's going to be in the direction.
I
Very
think
nice.
we came to the end. Huh?
Perfect.
Actually, I thank all the speakers for their nice presentations and also provocative talks. And I looked at the limits of the endoscopic surgery are enlarging. Yes.
Yeah.
Thanks a lot.
Okay.
Thank you so much.
Perfect. Thank you very much.
Thanks, everybody.
Bye.
Okay,
Okay.
thank you
Okay.
so much.
Goodbye.
Thank you.
Goodbye, everybody.
Bye-bye.
Thank you for coming.
Thank you.